involving the quantity of WBC. That is leukocytosis again. Leukocytosis or leukopenia. So this is about leukocytosis. Quantitative disorder of platelets, the neoplastic one. So what is leukemia then? Ekdom layman's term is blood cancer. Leukemia in layman's term is blood cancer, and that's what we are going to study today. So leukemia, we're going to study it in phases. Acute leukemias, then chronic leukemias. So today I'm going to give you a brief introduction on leukemia, and especially if a question on leukemia comes in examination, how you're going to approach. I'm not going to discuss any cases today, but rather I'm going to tell you the points based on which you have to approach a case of leukemia, especially in pathology. Lab diagnosis is very essential, and if you miss out on lab diagnosis, the bulk majority of the questions will be on, to a certain extent, on etiopathogenesis and then lab diagnosis. So here I'm going to discuss the lab diagnosis very well in general of acute leukemias before. So if you know the lab diagnosis over here, they are quite similar in acute lymphoblastic leukemia or acute myeloid leukemia. Then we will discuss the chronic myeloproliferative disorders, where we're going to stress only on the chronic myeloid leukemia, which is important from your exam point of view. So what is leukemia? What are the salient features of leukemia? What is your idea of leukemia? Can anyone tell me what is your idea of leukemia? It can be a myeloid leukemia. It can affect the myeloid lineage as well as the lymphoid lineage. So I'm asking you in general, what is a leukemia? What is leukemia? What will happen in leukemia? What is leukemia? Which cells are affected? Which cells are affected in leukemia? Sir? Progenitor blood cells, or rather stem cells, hematopoietic stem cells. So it's a disorder of the hematopoietic stem cell. What kind of disorder is it? What kind of disorder is it? It's a malignant disorder. So first and foremost thing, the salient features, remember these points, and in a nutshell, even though we should give nutshell in the end, but I've given it in the beginning. So if you remember these points, you have achieved something. So it's a disorder, it's a malignant clonal disorder of hematopoietic stem cells. It's a malignant clonal disorder of the hematopoietic stem cells. Point number one, it's a malignant clonal disorder of hematopoietic stem cells. Next point, which lineage is affected? Which lineage is affected? It can be the myeloid lineage, giving rise to AML, acute myeloid leukemia, or the lymphoid lineage, acute lymphoblastic leukemia. It can be the lymphoid lineage or the myeloid lineage. Okay, arises predominantly in the bone marrow, to a certain extent lymphoid, lymph node and thymus, those are lymphomas. Okay, lymphomas can have a spillover. So remember the bone marrow, predominantly the bone marrow, where it arises, predominantly the bone marrow, which is characterized by poorly differentiated blasts. Which is characterized by poorly differentiated blasts, means the adult WBCs do not form. The cells get caught at a very early stage. It remains in an undifferentiated stage. It does not differentiate much. Okay, so it is characterized by proliferation of poorly differentiated blasts, and if untreated, it's obvious that if it is untreated, the outcome is fatal. The outcome is fatal. So what are the points you must remember in case of leukemia? So if someone asks you, what is leukemia? So these are the things you must remember. Do not just by heart it, you should understand it. It's a malignant clonal disorder of what? Of hematopoietic stem cells. It arises from the hematopoietic stem cells. It does not arise from any soft tissues. It does not arise from any soft tissue. It doesn't arise from stomach. It doesn't arise from liver. It does not arise from any soft tissues or pancreas, whatever. So it arises from the hematopoietic stem cells. It arises from the hematopoietic stem cells. So it's a malignant clonal disorder of the hematopoietic stem cells, characterized by what? Poorly differentiated blasts. However you want to put it, it's up to you. Characterized by poorly differentiated blasts affecting the lymphoid or the myeloid lineage. If the lymphoid lineage is affected, you're going to get lymphoblasts. If the myeloid lineage is affected, you're going to get myeloblasts. Okay, so depending on the lineage affected, it's ALL or AML. You know what is ALL? You have heard of it. What is ALL and what is AML? Okay. Arises predominantly in the bone marrow, and the outcome is fatal if untreated. The outcome is fatal if untreated. So, তাহলে কিভাবে arise করতে পারে? The basic funda how a leukemia can arise. Self-renewal is maintained or increased and proliferation is increased. The self-renewal is maintained or increased and proliferation is increased. On the other hand, differentiation and apoptosis are blocked. So what happens if differentiation is blocked? The cells persist as undifferentiated cells. When differentiation is blocked, the cells do not mature into normal adult forms. They remain, they get caught at an undifferentiated stage. So differentiation is blocked. That is one point. Number two is apoptosis. If apoptosis is blocked, some cells must die. If cells do not die, they accumulate, they persist, develop genetic changes and become malignant. So apoptosis is also blocked. One is differentiation is blocked, the cells persist as undifferentiated cells. They may get caught at a stage of blast itself. And when apoptosis is blocked, the cells do not die, they accumulate. That is one thing you must remember. These things are blocked, and self-renewal and proliferation, they are maintained or increased, especially obviously what I have mentioned in the last slide, proliferation of poorly differentiated blasts. So this proliferation obviously is increased. This proliferation here is, so this sums up leukemia. Okay, see, it's a genetic lesion in hematopoietic stem cells. I've underlined also, or committed progenitors. This I have done during my post-graduation trip. So this is clear. Is this clear how a leukemia can arise? How a leukemia can arise? What changes can take place in the hematopoietic stem cells for a leukemia to arise? The cells will persist as undifferentiated cells. So proliferation is increased, self-renewal is maintained or increased. Differentiation is blocked. That's why they persist as undifferentiated cells, and apoptosis is blocked. The cells do not die by apoptosis. So what happens is the number goes on increasing. The number goes on increasing. So this is the basic funda of leukemia. Remember these points, okay? Having said this is basically the evolution. This is basically the evolution. If you trace the evolutionary history of leukemia, or rather this is actually the normal thing. The normal, this is how the red cells, your RBC, WBC and platelets differentiate. So they arise from the blood stem cell or hematopoietic stem cell. What you have just mentioned, blood stem cell or hematopoietic stem cell. Then they differentiate into, one is the myeloid series and the lymphoid series. So myeloid series থেকে কি আসতে পারে? What can come from myeloid series? The red blood cells, the platelets and the myeloblast. Red blood cells, platelets and the myeloblast. The myeloblast will give rise to what? The granulocytes, eosinophil, basophil, neutrophils. And other is the lymphoid stem cell. Lymphoid stem cell থেকে কি আসে? What comes from the lymphoid stem cell? Lymphoblast. Myeloid থেকে যদি myeloblast আসে, lymphoid থেকে কি আসবে? Lymphoblast. Lymphoblasts can be, again, they differentiate into lymphocytes and natural killer cells. So lymphocytes are again of B lymphocytes arising predominantly from the bone marrow, and T lymphocytes arising from the thymus, B and T. Okay, and then you got the NK cells, the natural killer cells, okay, associated with immunity. Is this clear? So if you trace the evolutionary history of blood cells, they have a common point of origin, a common source of origin. What is that? It's a hematopoietic stem cell. the hematopoietic stem cell or blood stem cell, which differentiates into myeloid and lymphoid lineage, So myeloid stem cells will give rise to what? RBCs, platelets, and myeloblasts, means WBCs. That can again be divided into granulocytes like eosinophil, basophil, and neutrophils. On the other hand, the lymphoid stem cell gives rise to lymphoblast. They differentiate further into lymphocytes, which is again categorized into B and T lymphocytes, depending on 80% are B lymphocytes, 20% are T lymphocytes. The predominant is B lymphocytes. B lymphocytes arises from where? Bone marrow. T lymphocytes arises from thymus, and then you get the NK cells, natural killer cells. So basically, so granulocytes and agranulocytes, they together form the what? Leukocytes, the WBCs. Okay, so this is basically the evolutionary history of blood cells. If you clear these things, if you have a clear-cut idea, it shouldn't be a problem for you to understand. So this is the leukemia percentage in India. Predominantly is CML, chronic myeloid leukemia. Then you get ALL, acute lymphoblastic leukemia, acute myeloid leukemia, and CLL, chronic lymphocytic leukemia. This is the percentage of leukemia that prevails in our country. Okay, so there's nothing much to study here. Now coming to the predisposing factors. So see, this is common to all acute leukemias. I am still not segregating acute leukemias with acute lymphoid or myeloid. You must have a clear idea of the acute leukemias before we segregate them into ALL and AML. There are certain differences between ALL and AML, which we will study when we study those particular leukemias. But as of now, today's class is predominantly focusing on the features of leukemias overall. So if you know the features of leukemia, it will become much easier for you to understand the individual leukemias once we study them. So what are the predisposing factors? One is hereditary, the other is acquired. So the hereditary includes what? ATM, like ataxia telangiectasia, Fanconi's anemia, Bloom syndrome, Klinefelter syndrome, Down syndrome, etc., etc. So these are the hereditary factors. Acquired is, the first and foremost thing is ionizing radiation. Ionizing radiation. Ionizing radiation, how do you acquire ionizing radiation? It can be a nuclear fallout. If you see many people who have survived the atomic bombs incident in Hiroshima, Nagasaki, they have developed certain kind of leukemias. In recent years, see the Chernobyl disaster in Ukraine. Okay, so these are examples where people have been affected with radiation. Then therapeutic irradiation. People receive therapeutic irradiation for many things. Whatever may be the cause, it can be for breast cancer, it can be for whatever may be the reason. People receiving for case of Hodgkin's lymphoma, people receiving irradiation, they are exposed to the risk of developing leukemias in near future. Then you get diagnostic X-rays. These are easy things, nothing much to explain. Point number 2 is chemical agents like benzene, alkylating agents, etc. Chemical agents like benzene, alkylating agents, etc. Third is viruses. What is HTLV? Human T-cell lymphoma virus, HTLV. Then EBV. What is EBV? Epstein-Barr virus, HTLV1, EBV. Then acquired conditions like MDS, myelodysplastic syndrome, PNH, paroxysmal nocturnal hemoglobinuria, AA. I have written the short form, so you know what is AA. Aplastic anemia. Do not write in exam as MDS, PNH, or AA. Write the full form. Then you get acquired. Then you get incidence of age and sex like children. Remember, 7-year-old boy presented with this. Related to hematopoietic. You know, it's a case of it's a hematologic malignancy. So what would be your diagnosis? At your age, do not think otherwise. Think in terms of an ALL. So predominantly children. There are exceptions. I don't deny the fact that there are exceptions, but as of now, for you, we're not going to give you too much of an exceptional question. We expect basics from you. So remember the basics. ALL predominantly involves whom? Affects whom? Children. AML predominantly affects the adults. Boys are affected more than girls in case of an ALL. Boys are affected more than girls in case of an ALL. In AML, the incidence is more or less similar. Okay, so these are all the predisposing factors that you must remember. Okay, so think in terms of an hereditary condition and an acquired condition. What comes in hereditary? Downs, Klinefelters, ataxia telangiectasia, Bloom's, Fanconi's. There are so many. Okay, then you get the acquired conditions like nuclear radiation exposure. How you get nuclear radiation exposure? You know all those. Expected, you know, it's very simple things. Then you get the chemical agents like benzene, alkylating agents. Then viruses like HTLV1, EBV. Various acquired conditions like myelodysplastic syndrome, paroxysmal nocturnal hemoglobinuria, aplastic anemia. Okay. Then you get the incidence of age and sex. Remember that ALL is predominantly for children. Children get affected by ALL more than adults. AML, adults. ALL, children. AML, adults. Remember that. And male are more affected than female in case of ALL. I mean, boys are affected more than girls. And equal incidence for AML. Okay, it is bone marrow failure. What can happen? Why it's a bone marrow failure? First question is, what is a bone marrow failure means? What is a bone marrow failure? Means what? Bone marrow failure kothatar mane ki? Means the normal hematopoietic stems, there will be so much proliferation of these undifferentiated blasts that they will replace the normal hematopoietic constituents out of the bone marrow, which means the normal RBC, the WBCs and the platelets have all gone. So once that happens, what can be the features? RBC is gone means you're going to get what? Isn't it? Think, bone marrow failure means the normal bone marrow, your bone do not contain the normal marrow elements. So the normal hematopoietic elements, that is the normal red blood cells, white blood cells and platelets, they have all decreased or they have been replaced by undifferentiated proliferation of undifferentiated blasts. So RBC, WBC, platelet jodi na thake, what can happen? No RBC means anemia. No WBC means leukopenia. And no platelet means thrombocytopenia. So what is it called? This is altogether known as pancytopenia. The entire thing is called as pancytopenia. So how will the patient present with anemia? What are the features? Weakness, fatigue, dyspnea on exertion, etc., etc. Bleeding. আমি anemia features জিজ্ঞেস করেছি. I'm asking you the features of anemia. Okay, think and answer. Number 2, leukopenia. Granulocytes are decreased. So how will the patient present with? Chronic infections, any kind of infections. You will never get a case history like this. Patient presented with 4-year-old boy presented with anemia, leukopenia. No, they will not give you like this. They will give you patient presented with a dyspnea on exertion or weakness or pallor. So you have to think in terms of, okay, if these features are present, that means this is a case of anemia. They can ask you questions like patient presented with chronic recurrent infections. Means patient is, the examiner is referring to leukopenia. Then thrombocytopenia means bleeding. Bleeding, various forms of bleeding. Bleeding from the gums, bleeding from the nose, that is epistaxis, etc., etc., etc. So features will be given to you and you have to understand, you have to calculate accordingly. So you must know the features. Patient will never present you with anemia. The examiner will never ask you questions like for 5-year-old boy presented with anemia, thrombocytopenia, leukopenia. No. They'll give you the features of anemia, they'll give you the features of leukopenia and the features of thrombocytopenia accordingly. So think and answer. Point, that is one thing. Number 2 is organ infiltration. Organ infiltration. Which organs are affected? Lymph node. Shopchage. The patient presents with firm, discrete lymph nodes. Firm, say cervical lymph node, which is firm and discrete. Generalized lymphadenopathy. It can be a cervical lymphadenopathy or it can be a generalized lymphadenopathy. The lymph nodes, the texture of the lymph node will be firm. Okay. Then spleen means splenomegaly. Liver, hepatomegaly. What? Having breakfast? Shouldn't have breakfast in the class. You should go out and have it. No problem. You go out and have it and come back. Are you okay with it? You can go out, have it and come back. No issues. I'm giving you 5 minutes. You too. And you also. Foremost thing is organomegaly. Remember the clinical features very well. Remember the clinical features very well because clinical features are the one which will be given to you in your exam. So remember the clinical features very well. Organomegaly, lymph nodes, generalized lymphadenopathy or cervical lymphadenopathy, whatever it may be, then splenomegaly and hepatomegaly. So splenomegaly is more common than hepatomegaly in case of a leukemia. So that is organ infiltration, the first thing. CNS is more common with ALL. CNS is more common with ALL. So if you get a CNS disease, a meningeal disease, features of a meningeal disease, irritability and all, intracranial tension, think in terms of ALL, not a AML. Exceptions are always there, I'm telling you, but as of now, think in terms of what is more common. ALL. So CNS disease, meningeal disease is more common with ALL. Gum hypertrophy. Gum hypertrophy is common with monocytic leukemia, AML M5. Remember, I'm not teaching you only ALL or AML here, I'm teaching you both. So remember gum hypertrophy. Gum hypertrophy, because a point gulo keno ami dichi, if you scan the question papers of last 10-15 years, these things have come. These things have come quite often and these are the features which have been put. So remember this table very well. Gum hypertrophy is more common with monocytic leukemia, that is AML M5, which will be taught to you. Again, bone pain and tenderness. Bone pain and tenderness again is more common with ALL. So ALL key features gulo common, CNS disease, bone pain and tenderness, they are very common with ALL. Gum hypertrophy, monocytic leukemia, means AML M5, monocytic leukemia. And lastly, you get chloromas. You know what is why chloroma? Because that is greenish in color. There will be proliferation of these blasts in soft tissues. Chloroma koththeke kothata esche jano? Any idea where this term came from? A bit greenish in color, chlorophyll. Chlorophyll you remember from botany. So, photosynthesis. So, chloromas are green to greenish color. That's why it has been termed chloromas. Again, oma. Why oma? Means it's tumor kind of thing. So, there will be swelling, proliferation of these blasts in all extramedullary sites. For example, the soft tissues. And because it's a bit greenish in color, so it has been equated with the chlorophyll. That's why it is called chloromas. Okay? So is this clear? Oh, sorry. And there's another one, some others. then you think in terms of others. What are the other features? Features due to hyperleukocytosis, viscosity of blood, sludging of blood flow, slowing down of blood flow. So what can happen then? What can happen then? Respiratory distress, headache. Basically blood will not flow to various organs. Blood flow will slow down, which effectively means the organs will be less perfused. Hyperviscosity will slow down the flow of blood. So features due to hyperviscosity. It can be anything. Then DIC. You know what is DIC? Disseminated intravascular coagulation. Disseminated intravascular coagulation. DIC is more common with AML M3. Why? Because there will be release of procoagulant substances from the leukemic cells. The AML M3 variant will release procoagulant substances from the leukemic cells. So remember these points. There will be bone marrow failure. Features due to bone marrow failure, that is one thing. Then features due to organ infiltration. In organ infiltration, remember ALL. In ALL, which organs are predominantly affected? The brain, meningeal disease, bone pain and tenderness. These are common with ALL. Whereas gum hypertrophy is more common with AML M5. Features due to hyperleukocytosis. Other features means features due to hyperleukocytosis means slowing of blood. There will be so much, there will be a lakh count, 1.5, 2 lakh count. So, which effectively means the total count is increased, and because the total count is increased, there will be sludging of blood, slowing down of blood flow, hypoviscosity. This will give rise to features due to hyperviscosity or features due to hyperleukocytosis. Then comes DIC, disseminated intravascular coagulation, which is more commonly seen in AML M3. Why? Because there is release of procoagulant substances into the blood from the leukemic cells. So, these are the features you must remember. Clinical features is very, 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 very important. If you do not remember the clinical features, you will not be able to know leukemia, you will not be able to answer leukemia properly. Mind it. Okay? May I go to the next slide? Is it okay? Remember the clinical features, features due to failure of bone marrow, features due to infiltration of the organs, and other features like features due to hyperleukocytosis and DIC. Is this clear? May I proceed to the next slide? Okay? Now coming to the diagnostic criteria, how you're going to approach. Very important, 5 to 6 marks question, at least 6 marks you're going to get on laboratory features. So if you do not know the laboratory features, you won't get anything. So think in terms of this. How do you diagnose a case of acute leukemia? What is the main aim? What is the main aim? How are you going to approach a case of leukemia or laboratory investigation? What investigations are you going to put? So before that, you should know why I should do a lab investigation in the first place. So what are the various aims? First and foremost is to establish the presence of leukemia. To establish the presence of leukemia. The first and foremost thing is leukemia ache, setake tomay identify korte hobe. Right, that is the most important thing. Then distinguish leukemia from other conditions. How are you going to diagnose a case of leukemia? When you see the total count, when you see the peripheral blood smear, you can guess that this is a case of leukemia. So you know that this is a case of leukemia. So leukemia has been identified in the first place. Second point is differential diagnosis of leukemia. There are various things which resemble leukemia. For example, myelodysplastic syndrome, hematogones, your non-Hodgkin's lymphoma infiltrating the bone marrow. Distinguish it from other neoplastic and reactive conditions. Then, distinguish AML from ALL. Third is distinguish leukemias, distinction of leukemia, whether it belongs to the myeloid series or whether it belongs to the lymphoid series, and then classify AML into specific subtypes. whether ALL L1, L2 or L3, or whether it's AML M1, M0, M1, M2, M3, whatever it may be. So এই জিনিসগুলো তোমাদের কিন্তু মাথায় রাখতে হবে. Establish the presence of acute leukemia, distinguish it from other neoplastic conditions and reactive conditions, number 2. Number 3 is distinguish AML from ALL. And finally, classification of ALL and AML into specific subtypes. To do that, we have to depend on these 5 investigations. To do that, we have to depend on these 5 investigations. Morphology of PB and BM. What is PB? Peripheral blood. Morphology in peripheral blood and bone marrow. Number 2 is cytochemistry. Number 3 is immunophenotyping. Number 4 is cytogenetic analysis. And number 5 is molecular genetic analysis. So if you don't remember anything, at least write the headings. At least write the headings. You get some marks. Okay, so you have to write the headings at least. Don't write anything rubbish, just write the headings. Simple thing, pachta point. This is 5 points you can't remember. It's so simple. Peripheral blood and bone marrow. Morphology of the cells, blast cells in peripheral blood and the bone marrow, that is 1. Number 2 is cytochemistry. Number 3 is immunophenotyping. Number 4 is cytogenetic analysis, and then molecular genetic analysis. They work hand in gloves, mind it. They work hand in, they do not work in isolation. Every investigation is dependent on the other. We do one investigation, then we go for another investigation. The higher you go, sometimes we can identify based on peripheral blood and bone marrow, we can identify. But sometimes when peripheral blood and bone marrow fails to help us identify the features, we go for higher features like cytochemistry, then we go for immunophenotyping. So whatever it may be, remember, they do not work in isolation, rather they are hand in gloves. একে অপরের পরিপূরক, এই কথাটা মাথায় রাখবে. They don't work in isolation. Each and every investigation has a purpose, and we need each and every investigation to identify, to finally type the case of leukemia. What leukemia it is, categorizing into, subcategorizing into various subtypes and all. So these 5 points must be remembered. Morphology of peripheral blood and bone marrow, cytochemistry, immunophenotyping, cytogenetic analysis, and finally molecular genetic analysis. I'm not explaining too much in details for you. So first and foremost, sorry, I made a mistake. So first and foremost thing is morphology. Morphology of peripheral blood and bone marrow. So you have done a peripheral blood, then the clinician asks for a bone marrow. So bone marrow is diagnosis and morphological subclassification of acute leukemia. Why should we do a bone marrow? Confirmation of diagnosis in peripheral blood and further morphological subclassification of acute leukemia. So the total count may be elevated, predominantly it's elevated, but in some cases it may be normal or low. For example, cases of subleukemic leukemia. For example, cases of subleukemic leukemia and aleukemic leukemia. In subleukemic leukemia, the total count is normal or low. The total count is normal or low. But blasts are demonstrable in peripheral blood. You get a total count of say 10,000 or 8,000, 9,000. That is very normal. But when you see the peripheral blood, when you see the blood smear after staining it with Leishman stain, you get what? You get blasts. Normal or low, but blasts are demonstrable in peripheral blood. Then aleukemic leukemia. Aleukemic leukemia means what? In peripheral blood, blasts are absent, but they are demonstrable in bone marrow. In peripheral blood, blasts are absent, but they may be demonstrated in the bone marrow. Right, so remember this point. Examiner may ask you what is a subleukemic leukemia, what is a aleukemic leukemia. In subleukemic leukemia, the total count is normal, but blasts are demonstrable in peripheral blood. In leukemic leukemia, blasts are absent in peripheral blood, but they are demonstrable in bone marrow. So these are the conditions where you may get a low or a normal leukocyte count. Right? So remember, these exceptions are always there, not always. Predominantly 90%, 95% of the cases you're going to get a high leukocyte count, leukocytosis. So TLC is elevated, but in some cases it may be normal or low. For example, subleukemic leukemia, total count is normal, blast demonstrated in sub. Sub means low. Subleukemic leukemia where total count is normal, but blasts are demonstrated in peripheral blood. At leukemic leukemia where you won't get blasts in the peripheral blood, but if you do a bone marrow, you're going to get blasts. And finally, buffy coat. In some cases of leukemic leukemia, when peripheral blood smear is absent, you know what is a buffy coat? In Winthrop's tube, when blood is centrifuged, it forms 3-layer RBC, platelets. In between, you have a small buffy coat. So if you take a buffy coat and do a smear, এটা তোমরা Winthrop's colony বলে, PCV examination এ লাগে এটা, Winthrop's tube. So if you do a buffy coat and take that small layer and smear it and make a smear out of that buffy coat and stain it with Leishman stain, you can get blasts in peripheral blood also. So buffy coat demonstration, just remember this point, you don't have to do it manually. Just remember this point. In buffy, if you do a buffy coat examination, if you do examine a buffy coat, make a smear out of a buffy coat, you can demonstrate PBS. You may demonstrate PBS in case of acute leukemic leukemias. Okay, so now let me go back to this. So the main thing is you have to identify in peripheral blood or bone marrow, we have to identify whether it's a lymphoblast or a myeloblast. So what are the features of lymphoblasts? Myeloblasts are a bigger than lymphoblasts. Size. So first and foremost thing, when you compare the size, myeloblasts are a bit bigger than lymphoblasts. The nuclear membranes of myeloblasts will be very fine, whereas that of lymphoblasts will be dense. Cytoplasm, because the myeloblasts are larger in size, the cytoplasm will be moderate, or it will be more than that of a lymphoblast. In lymphoblast, the cytoplasm will be very scanty. Nucleoli will be at least 3 to 5, depending on which stage you get that myeloblast. Number of nucleoli will be a bit more in myeloblast than in case of at least a schematic diagram of a lymphoblast and the myeloblast. Remember this, draw the diagram. Myeloblasts are a bit bigger than lymphoblasts, and because they are a bit bigger than lymphoblasts, the cytoplasm will be moderate, whereas in lymphoblasts, the cytoplasm will be scanty. Number of nucleoli will be more in myeloblasts than in case of a lymphoblast. And or rods will be present in case of AML, whereas in ALL, or rods are absent. Okay. So coming to cytochemistry. Now, in some cases, what happens is bone marrow and peripheral blood and bone marrow is not enough. They do not help us to identify the case of leukemia, or at least if we know leukemia, we have to further subclassify leukemia, right? Sometimes we fail to understand based on the morphology on peripheral blood and bone marrow whether it's a lymphoblast or a myeloblast. That's when we take the help of cytochemistry. Again, as I said, they work in hand in gloves. They help in difficult morphologic cases. We fail to identify whether it's a lymphoblast or a myeloblast. So with morphology and cytochemistry, 80 to 90% of the cases can be diagnosed accurately. The accuracy goes up to 80 to 90% with morphology and cytochemistry. When immunophenotyping is added to it, with morphology and cytochemistry, when we add immunophenotyping, the accuracy goes up to 95 to 99%. So as I said, they work hand in gloves. They do not work in isolation. So the main aim is to distinguish ALL from AML in difficult scenarios, when morphology is not helping us, or morphology is such that it is not helping the pathologist to differentiate a lymphoblast or a myeloblast, that's when we take the help of a cytochemistry. So what are the things that are identified in case of cytochemistry? Because these cells will have various substances, for example, enzymes, glycogen, fat. So cytochemical stains will identify these particular substances in the cells, enzymes, glycogen, fat, and based on this, which are present in the particular blast cells, and based on this, we will be able to subtype leukemias into various categories. Okay. So coming to the stains used, just remember the names of the stains. MPO, myeloperoxidase. What is myeloperoxidase? Myeloperoxidase is basically an enzyme which is present where? In the acidophilic granules of neutrophils. Which is present in the acidophilic granules of the neutrophils. MPO, myeloperoxidase. You have heard of it. MPO, you have heard of it. You know the primary granules, the secondary granules, the acidophilic granules. That is the primary granules of the neutrophils. They contain myeloperoxidase. So AML M0, M1, M2, M3, they are basically the cells of myeloid series. So basically it's a neutrophil series of cells. So if these cells belong to the neutrophil series, obviously they'll contain the enzymes MPO, myeloperoxidase. So myeloperoxidase is one of the most important cytochemical stains which is used to identify AML M0, M1, M2, M3. Why it is called AML M0? Because AML M0, there will be block-like positivity. I'm coming to the pictures later. Just I'm showing you. Hang on. So this is what I mean. See MPO positive. See how it is like a diffuse granular positivity in case of myeloblast. Diffuse granular positivity in case of a myeloblast. This is what I mean. So cells of AML M0, M1, M2, M3, they will be positive for MPO along with Sudan black B and chloroacetate esterase. The reaction with chloroacetate esterase is not as good as with MPO or Sudan black B. So when you are identifying AML M0, when you are identifying to identify AML M0 or AML M0 আমি বলতে গেছিলাম কি in light microscopy, in AML M0 in light microscopy, the positivity cannot be demonstrated, but to demonstrate it, we have to use an electron microscopy. That's why it's called AML M0, okay. Then comes non-specific esterase. Non-specific esterase is ANAE, alpha naphthyl acetate esterase. Remember the names. Remember the names. Alpha naphthyl acetate esterase, alpha naphthyl butyrate esterase, naphthol ASD, then naphthol ASD acetate esterase. Just remember non-specific esterase. Remember the names non-specific esterase. Non-specific esterase will be common in AML M4 and M5. AML M4 and M5, it will be non-specific esterase. That is the monocytic lineage. The monocytic lineage will be positive for, I'll explain again when I teach you the particular leukemias. So AML M4 and M5, the monocytic lineages will be positive for non-specific esterase. Sometimes we use MPO, some cases we'll have myeloid and monocytic lineage together. In that case, we use MPO or chloroacetate esterase or Sudan black B along with non-specific esterase. So that is called a double esterase reaction. That is called a double esterase reaction. Okay, just remember the names. I'm not getting into the details. Then PAS, paradic acid shift. Have you heard of the paradic acid shift? PAS to demonstrate glycogen. Yes, it is. PAS is paradic acid shift. So it's basically an oxidizing agent which converts glycol into aldehydes, and the aldehyde reacts with Schiff's reagent to form a magenta colored red or magenta colored compound. So PAS will be positive in BALL, block-like positivity in case of BALL, and in AML M6 it will be positive in erythroblast. Remember this. And acid phosphatase will be positive in TALL. So remember this AML M0, the cytochemical reactions in acute leukemia is given. Remember the MPO at least. Remember the MPO, myeloperoxidase in AML M0, M1, M2, M3, NAC in AML M4, M5, PAS predominantly in BALL, means in myeloid series, remember the MPO and NAC and Sudan black B, For lymphoid lineage, remember PAS. Which lymphoid lineage? BALL. And in TALL, it is AP, acid phosphatase. Okay. There's nothing much to explain over here. You have to remember it. So this is basically the reaction that I'm talking about in case of, see, this is MPO positive in myeloblast. PAS is diffuse or weakly positive. These are the reactions in AML, M1, M2, M3. And NAC will be negative because NAC highlights what? The lymphoid lineage, so your monocytic lineage. Then again, in case of AML M4, see, NAC will be diffusely positive here, and in MPO will be block-like or small granular positivity. Cytochemical reaction in AML M5. AML M5 monocytic lineage means NAC positivity, whereas in case of BALL, in case of ALL, PAS is block-like positive. Block-like positivity. Just remember these points. If you write these points, full marks you're going to get in exam. Okay. Then comes to immunophenotyping. So the principle of immunophenotyping is these leukemic cells will have particular antigens on the surface. They will have particular antigens on the surface, which has been classified as CD, means cluster of differentiation. So each CD is specific for each lineage. So it depends, what does it reflect? It identifies the cellular lineage and the stage of development. Identifies the cellular lineage and the stage of development. What happens here is the antibodies are stained with fluorescent markers. The antibodies are stained with fluorescent markers and their reactivity against specific antigens is identified. So that is basically the principle of how immunofluorescence works. So what are the methods employed? Immunofluorescence and flow cytometry. The flow cytometry, I have put it in orange color is and underlined it, made it bold and in italics is. Flow cytometric analysis is the preferred method of choice because the leukemic cells are in fluid suspension in blood and bone marrow. So remember flow cytometric analysis in case of immunophenotyping, where on the surface of blood cells, whether it's the nucleus or the cytoplasm or the nuclear membrane or the membrane of the cell, there will be CD, cluster of differentiation antigens, and in antigener pechone, what we do is we employ various antibodies, mark it with fluorescent markers and see the reactivity against this particular antigens. So this is basically the principle of immunophenotyping. So what are these various CDs we identify? So what are the applications? Diagnosis and classification, again they are more or less similar. Assessment of prognosis. Assessment of prognosis, how well the patient is responding to chemotherapy or whatever treatment is employed. Then identification of MRD, minimal residual disease. What is a minimal residual disease? Minimal residual disease means after treatment has been given, one leukemic cell persists, one leukemic blast persists among all normal cells. So we identify that particular cell. It is called minimal residual disease. After residual cell pore ache, one residual cell which is a leukemic cell is lying among various other normal cells. MRD is seen only after treatment is given. Once treatment is given, all the leukemic cells have died. Out of that normal cells, the bone marrow is now full of normal cells. So in between all the normal cells, we identify one leukemic cells. So that is called minimal residual disease. Then to monitor the effectiveness of monoclonal antibody therapy against antigens on leukemic cells. For example, rituximab against CD20. So what are the various antigens we identify? So this is basically, you cannot remember, I know it. It's not easy for you to remember all the slides. So in myeloid series, the predominant CD is CD13, CD33. CD13 and CD33 is the primary panel of antigens that we identify. Okay, these are present in the myeloid cells. In B lymphoid series, CD19, CD79A, CD22, CD10, etc., etc. So these are basically all the antigens. Just remember 2 or 3 of them. Take this PowerPoint and remember 2 or 3 of them. If you get in the book, it's okay. For post-graduation, you must remember each and every series, okay? So this is the primary panel and this is the secondary panel. But at least you know, you should know why we do our immunophenotyping. You may not remember the panels of antibodies that is used, okay? But at least you should know the principle of immunophenotyping and why it is used. It helps in identification of AML, M0, M6 and M7. M6, what is M6? Acute erythroblastic leukemia. Acute erythroblastic leukemia, in erythroblasts, there is something called glycophorin. There is something called glycophorin on the surface, glycophorin A, which is identified, and in case of AML M7, which is acute megakaryoblast leukemia, means platelets, we identify two surface antigens, CD41 and CD61. CD41 means GP2B3A and CD61 means GP3A. Then identification of actually it's over because this guy is waiting. Bilineage and biphenotypic leukemia, I'll explain you later, and small round malignancies, small round cell malignancies. Remember this. And then comes cytogenetic and DNA ploidy studies. Again, ploidy means identifying the number of chromosomes. So ploidy study is very essential. It helps in prognosis. Chromosome number is determined. In ALL, when I teach you the prognosis, I'll talk about the hyperploidy and hypoploidy. Hyperploidy means more than 50 chromosomes, which have better prognosis than diploid or hypoploid DNA. So these are the basic various abnormalities which are identified, and each chromosomal abnormality has a favorable as well as an unfavorable prognosis. Some chromosomal abnormality, for example, T821, Q22, Q22, T8, T15, 17, Q22, Q12, they have favorable prognosis. Then abnormalities of 11, Q23 has an intermediate prognosis. So it depends, depending on various chromosomes. You cannot remember it, even I cannot remember it. I know it's not easy to remember. Remember one or two of them which has a favorable prognosis and the one which has an unfavorable prognosis. Okay, এগুলো কিন্তু সব লাগবে আবার. You need everything when you study specific leukemias. And finally, the molecular genetic studies. Just remember the name, molecular genetic analysis. The methods used are PCR, polymerase chain reaction, FISH, FISH, fluorescence in situ hybridization, then southern blot, etc., etc. It helps to identify the lineage. এগুলো মোটামুটি the purpose of all these studies are to a certain extent from cytogenetic analysis, molecular genetic analysis, they are more or less similar, identifying the minimal residual disease and all. So this finishes your topic for today. And next class will be ALL.
So the three main agents that is known as the hematinics and are required for blood formation are the iron, folic acid and vitamin B12. Okay. So these three are the important. We'll discuss about these three. So what do we mean by anemia? So anemia, you know, this is basically a condition in which the balance between the production and destruction of the RBCs is disturbed. So you know the lifespan of every corpuscle for the RBC, that is the 120 days. So if this destruction and formation is not balanced, so either there may be blood loss, that blood loss may be acute or chronic. Acute means there may be some road traffic accident. So there may be anemia, iron deficiency anemia, or chronic blood loss. For example, there may be some hemorrhoids, that is the piles, or there may be some bleeding peptic ulcer. In these cases, there will be chronic blood loss over the months or years. That also leads to anemia. Next is impaired cell formation. So if there is deficiency of the essential factors like iron, vitamin B12 or folic acid, or if there is bone marrow depression. Already in the pathology you have read about the different types of the leukemia, na? So leukemia is ongoing. So if there is bone marrow depression, for example in aplastic anemia, there occurs some bone marrow depression. This mainly occurs anemia due to erythropoietin deficiency. So erythropoietin is another hormone that is secreted from the kidney and that helps in the erythropoiesis. So deficiency of the erythropoietin also results in anemia. And lastly, the increased cell destruction, that is the hemolytic anemia. You will read more about this in the medicine. So hemolytic anemia, there may be different types of the hemolysis. there may be intravascular hemolysis or extravascular hemolysis. So all these can occur due to the different diseases or conditions that also leads to anemia. So these are the basics of the anemia. These are the main three reasons by which the anemia develops. Now coming to the iron. Iron is one of the many important essential element of our body. Okay. At the same time, you know, the iron may be present as the ferrous form and the ferric form, and this iron is also metabolized to formation of the different types of the oxides, that is the free radicals, singlet O2 or OH minus. So if there is more iron in our body, that also leads to detrimental effects to different organs. And if there is less iron in our body, that leads to anemia, iron deficiency anemia. So both way it will be problematic. So the major roles of the iron in mammals is the carry oxygen as part of the hemoglobin. You have already also read about the structure of the hemoglobin. Just revise this in the evening in the physiology, that how the hemoglobin is formed. So there is globin and there is heme, and how the oxygen is saturated and how the oxygen is transported by means of the hemoglobin. So iron deficiency is most important form of the malnutrition, and globally 50% of the anemia is attributable to iron deficiency. So you will see in the wards, you will see after passing MBBS that many of our patients are anemic, more so in case of the females, and in 90% of the cases this anemia is due to the iron deficiency. So iron deficiency anemia is quite prevalent in our country, and you have to treat this iron deficiency anemia. So how this iron is distributed in our body? So total body iron is approximately 2.5 to 5 gram. It is more in men than in women. And within hemoglobin, 66% of the total hemoglobin is there. As ferritin and hemosiderin storage, 25%. As myoglobin, which is present within the muscles, approximately 3%. And parenchymal iron, that is within the cells, approximately 6%. And you know this hemoglobin is basically a protoporphyrin, each molecule having 4 iron containing heme residues amounting to approximately 1.1 milligram of iron per ml of red blood cells. And it has 0.33% of iron. These are all statistics about how the hemoglobin is formed. So this is the daily requirement in our body. So to make up average daily loss, iron requirements in adult males is approximately 0.5 to 1 milligram, in females 1 to 2 milligram, in infants 60 microgram per kg, in children 25 microgram per kg, and in pregnancy there is more requirement of the iron and it increases to 3 to 5 milligram. That's why you can see that in pregnancy, in majority of the cases, iron replenishment is done, irrespective of the iron status. So these are the dietary sources of the iron. So rich sources, this is more iron containing foods at the liver, different liver of the different animals, egg yolk, oyster, dry beans, dry fruits, wheat germ and yeast. This contains large amount of the iron. Medium amount of the iron is there in meat, chicken, fish, spinach, banana and apple, and very poor iron is there in the milk and milk products and root vegetables, for example potato. Okay, so if a patient is anemic, we have to also tell about the dietary changes to the patient in accordance to the iron replacement. So we have to tell about this. Okay, so how the iron is absorbed in our body, this is important for your examination. So what happens? So what we are taking iron by different types of the foods. So this is the dietary iron. Now this dietary iron is basically present in the foods in two modes, either in the ferric form or in the ferrous form, and another form is the heme form. So if it is present in the heme form, it is directly absorbed within the mucosal cells in the our intestine. If it is ferric form, it has to be converted to ferrous form by means of the different acid and reducing agent present in our stomach, because in ferric form the iron cannot go inside the mucosal cells. So ferric form has to be converted to ferrous form. If some iron is already present as ferrous form, it goes within the mucosal cells by means of a transporter. This is known as the divalent metal transporter 1. So divalent metal transporter 1 is present in the mucosal areas of the intestine, and by this ferrous iron goes within the mucosal cells. Within the mucosal cells, some part of it is converted to ferric iron and it is stored as ferritin. within the mucosal cells. And some part, in majority of the part, by means of the another transporter, this is known as the ferroportin. So FP1 is the ferroportin. It goes within the plasma by means of the interstitium. So this is the interstitial border. So in the interstitial border, the transporter name is the ferroportin, and in the mucosal border, the transporter name is the divalent metal transporter 1. So these two transporters are important for iron absorption. So by means this ferrous, by means of the ferroportin, it goes inside the plasma. In the plasma, it is again converted to the ferric form, and this ferric form is bound to another transporter protein. This is known as the transferrin. So within the blood, within the plasma, iron is transported to different organs by means of a protein known as the transferrin. So this is the transferrin, this is the ferric iron. So some part of it is go to different types of the cells, some part is stored within the reticular endothelial cells like liver, spleen, etc. Large amount of the iron storage is present in our liver. Okay. So in the liver it is stored most commonly as ferritin, some part it is converted to also hemosiderin also, and it is enters within these cells by means of this transferrin receptor. So TFR, it is the transferrin receptor, and some part it goes to the erythrocyte precursor cells where it is converted, it is attached with the heme, and ultimately it leads to oxygen carrying capacity. So this is in a nutshell about the iron absorption. So this is very important. So average daily diet contains approximately 10 to 20 milligram of iron. What we are eating every day, this is the average. So we are taking 10 to 20 milligram of iron. Its absorption occurs all over the intestine in the mucosal cells. Majority occurs in the upper part of the intestine. Dietary iron is present, already I have told, either as the heme or inorganic iron. Absorption of heme iron is better and occurs directly without the aid of a carrier. So if the iron is present as a heme form, no carrier is needed to intrude within the mucosal cells. And the major part of the dietary iron is inorganic, and this inorganic form is most of the cases they are in the ferric form. This ferric form needs to be converted to the ferrous form to get absorbed within the body. Already said, two transporters are there. In the luminal membrane or mucosal membrane, there is divalent metal transporter 1, and in the interstitial or basolateral membrane, ferroportin 1. So these two are the transporters. The same thing I have already told. This is how it is absorbed. So these are the factors which affect iron absorption. This is also important because there are some things that facilitate absorption, some just impedes absorption. If there is acid, acid means it is in the stomach. If ascorbic acid, that is the vitamin C, amino acid containing SH radical, that is present in some fruits and meat, these facilitates the absorption of the iron in our body. While the alkalis like antacids, phosphates, phytates, these are present in different types of the vegetables. Tetracycline and other food in stomach, ultimately they impedes absorption of the iron. So when we are giving the iron tablet to a patient, we can determine that what are the agents that should be taken before taking the tablet or should not be taken any food according to these facilitating and their impeding factors. So another thing is known as the mucosal block. So our intestine or gut has a mechanism to prevent entry of excess iron in the body. Already I have told that if the iron is excess in our body, that ultimately leads to different types of the oxygen free radicals, and that free radicals leads to oxidative damage to our cells. So if there is iron overloading, most of the iron is stored as already we have seen within the, you can see, within this mucosal cell itself. So some part of the iron is stored. If we are taking more iron, more part of it is stored as ferritin. So ultimately, this is known as the ferritin curtain. The ferritin generally remains stored in the mucosal cells and is lost when they are shed. So shedding of the intestinal mucosal cells, normal shedding occurs within 2 to 4 days. That shedding occurs and ultimately that goes outside our body through the stool. So this is known as the ferritin curtain. So basically this is a keep-safe mechanism by which there will be no iron toxicity in our body. This is known as the ferritin curtain. So iron status of the body and the erythropoietic activity govern the balance between these processes. So how much iron is absorbed, how much iron goes to the plasma, how much iron will be stored as storage compartment. Ultimately, all this depends upon what is the iron storage in our body. If in iron deficiency anemia, there will be less iron storage, so there will be more iron available to the different types of the cells from the storage. And if there is less need of the iron, more is stored as iron, ferritin or hemosiderin in different types of the cells, most commonly in the mucosal cells and then the different types of the reticuloendothelial cells. So iron transport, already we have seen transferrin is there. So it is complexed with a glycoprotein transferrin in the plasma, and by which it goes to the different types of the cells. The iron circulates in plasma bound to transferrin, 2 ferric residues per molecule. The total plasma content of iron is 3 milligram, and it is recycled by means of the enterohepatic circulation 10 times every day. So turnover of iron is approximately 30 milligram per day. So it goes to the different types of the cells, and by means of the transferrin receptors, it is ultimately goes inside the cell. So ultimately, this is a iron cycle, you can see, and it dissociates from the complex at the acidic pH of the intracellular vesicles. When it goes inside the cell, it ultimately comes within the intercellular vesicles, and within the vesicles there are acidic pH where it is again dissociated from the transferrin. The released iron is utilized for hemoglobin synthesis or other purposes, while the transferrin and transferrin receptor are returned to the cell surface to carry fresh loads. Okay. In iron deficiency and hemolytic states, that is the hemolysis, more RBC are broken down. When Briggs erythropoiesis is occurring, erythropoietic cells express more transferrin receptors, so that more transferrin bound iron are captured by means of the different types of the cells, selectively more efficient in trapping iron. So you can see so basically, when according to the iron requirement in our body, the transferrin saturation, all these acts. Iron is stored in the reticuloendothelial cells, already I have seen, that is the liver, spleen, bone marrow, hepatocyte, myocytes as ferritin and hemosiderin. Okay. Parenchymal iron, that is the iron present within the cells, that basically leads to the formation of the different types of the cellular enzymes like cytochromes, peroxidase, catalase, xanthine oxidase, etc. And iron is tenaciously conserved by the body. Daily excretion is very less, approximately 0.5 to 1 milligram, mainly as exfoliated gastrointestinal mucosal cell. And in menstruating women, monthly menstrual loss may be average to 0.5 to 1 milligram per day. So when there is iron deficiency anemia, we can measure the transferrin saturation and ferritin level also. So by means of the ferritin level, we can determine what is the total body iron content storage form. By means of the transferrin saturation, we can assure that is the how much amount of the transferrin that is present in the plasma is saturated by the iron. So all these parameters can be measured. So this is very important. The iron absorption, iron metabolism, this is very important for your exam. So now coming to the iron tablets or iron preparations. In most of the cases, iron is available as the tablet form. In some of the cases, it is also present as syrup form also. So mostly ferrous sulfate is used, 100 to 200 milligram. Iron liquid preparation is given mainly in case of the children. So there are different types of the salts. Apart from the ferrous sulfate, there may be ferrous fumarate, ferrous succinate, ferrous gluconate, etc., carbonyl iron, etc. But most commonly, ferrous sulfate, ferrous fumarate, ferrous succinate. These three available are market. Okay, so different types of the iron tablets. So usually how it is given? The optimum dose if there is iron deficiency anemia is 200 milligram per day. Now this 200 milligram elemental iron should be divided between the 2 to 3 doses, and it should be given ultimately leads to maximal hematopoietic response. Prophylactic dose, that is if there is in case of the adolescence or pregnancy, it may be given 30 milligram iron daily. But the problem of the iron is in many of the cases gastric irritation and constipation can occur. Many of the patients also feel nauseous. There may be some bad taste in the mouth. So if we are giving the iron tablets in the large amounts, for example 2 to 3 times daily, many of the patients are not adherent and they discontinue the tablets. And particularly this problem occurs if the iron is given in the empty stomach. Now you can remember that when there is food in the stomach, the iron absorption is more. So it should be given, iron absorption will be, if there is food, iron absorption less. But in empty stomach, the iron absorption is very good. Remember, but the problem is in empty stomach, there will be more problem of the gastric irritation. But if we are giving iron in the full stomach, there will be less gastric irritation and there will be less absorption also. So according to the patient profile, we have to determine whether the iron tablets should be given in the empty stomach or in the full stomach. Okay, so this is important. So I am telling, ideally iron tablets should be given in the empty stomach, because in empty stomach absorption of the iron is good. But in the empty stomach, there is more chances of different types of the adverse effects. Most common, gastrointestinal intolerance. There may be some nausea, there may be vomiting, constipation, etc. etc. So if we are giving iron tablets after food, these problems will be minimal, but the absorption is also less. So there will be more time is needed for correction of the iron deficiency anemia. Okay, so this is written here. Now coming to the parenteral iron therapy. In some cases, iron is also given by injectable routes. So what are the areas, what are the indications? This is also important. So when oral iron is not tolerated at all, so we are giving the oral iron after food. In spite of this, the patient cannot tolerate the oral iron, bowel upset is too much. In these cases, we have to give the injectable formulation. Failure to absorb oral iron, if there is different types of the intestinal problems, malabsorption syndromes or inflammatory bowel disease, in these cases we have to give the injectable iron. Chronic inflammation like rheumatoid arthritis decreases the iron absorption and the rate at which the iron can be utilized. Non-compliance to oral iron, the patient is not taking the tablet as it should be taken. In presence of the severe deficiency with chronic bleeding, because with oral formulation it needs time for correction, and along with erythropoietin. In most of the cases when there is chronic kidney disease, that is also associated with iron deficiency anemia. In chronic kidney disease, if the anemia is there, we have to give the erythropoietin. And when we are giving the erythropoietin, there will be Briggs erythropoiesis, and for erythropoiesis iron is also needed. That's why we have to give more iron at that time. That's why parenteral iron is to be given. So these are the indications of the parenteral iron therapy. So what are the preparations? Iron dextran and iron sorbitol citric acid. These two are the previously used. Nowadays very less used, but it is easier to because it is very cheaper. But the problem is anaphylaxis and allergy happens very much in these cases. That's why it is not used nowadays. Just remember the names: iron dextran, iron sorbitol citric acid. Now ferrous sucrose is also used. This is the newer ones. Newer formulation, higher molecular weight complex of iron hydroxide with sucrose, safer. Dose, you have to calculate the dose according to this iron requirement, 4.4 into body weight in kg into hemoglobin deficit, and you have to give the ferrous sucrose, injectable formulation. Incidence of the hypersensitivity reaction is less, and 5 days after last injection. So it can be given by injection. And remember, in all of the injections, anaphylaxis and allergy is very much there, but with the newer formulations, this anaphylaxis is lesser. This is another newer one, ferric carboxy maltose. This is ferric hydroxide core with a carbohydrate cell, rapidly taken up by the reticuloendothelial cells, administered daily 100 mg IV injection or up to 1000 mg diluted with saline and infused IV taking 15 minutes or more. That is, it is slowly infused because there is always chances of the anaphylaxis. Incidence of the acute reaction is low, headache, nausea, abdominal pain is mild. So remember the name ferric carboxy maltose, very commonly now used if the injectable formulation is used. And the latest one is the iron isomaltoside 1000. Okay. So this was marketed in India in 2016. This is the latest addition. Nowadays this iron isomaltoside and ferric carboxy maltose is mainly used as parenteral iron therapy. It is basically an iron bound tightly in a matrix of iron isomaltoside 1000, which is a oligosaccharide with a mean molecular weight of 1000. Okay. So after IV injection, again it is taken up by the reticuloendothelial cells. Tight binding occurs. So toxicity is lesser with this. Permits administration of the high single dose, low immunogenic potential, convenient and cost saving due to single short period IV infusion. So ferric carboxy maltose, basically it is given by infusion, and this iron isomaltoside can be given by injection as well as by the infusion. That is, in both ways it can be given by means of a single injection or infusion for a larger period of time. So remember these names, very important: iron dextran, iron sorbitol citric acid. Older ones, newer ones is ferrous sucrose, ferric carboxymaltose, and iron isomaltoside 1000. This parenteral iron therapy is also very important for your exam. It will come as short note or in the viva. Now, where it is used, iron is used mainly in the iron deficiency anemia. Most commonly, already I have said that iron deficiency anemia is quite common in our country. Apart from this, it has also been used in megaloblastic anemia. Megaloblastic anemia mainly happens due to the vitamin B12 and folic acid deficiency, but it is iron deficiency is also there in most of the cases. So we need the iron replenishment in these cases also. And in some of the cases, as an astringent as throat pain, when there is throat irritation, ferric chloride is used. So mainly in the iron deficiency anemia. So adverse effects already we have discussed, mainly the different types of the gastrointestinal intolerance, like nausea, epigastric pain, diarrhea, constipation, both can occur. Staining of teeth, metallic taste in the tongue. Tolerance to iron, oral iron can be improved by initiating therapy as a low dose. So we should start with a low dose and then we should build up the dose. And it should be taken with the food if there is more adverse effect. And there may be some local and systemic side effects when we are giving the parenteral iron therapy. There may be pain at site of injection, pigmentation of skin, sterile abscess, fever, headache, joint pain, etc. can occur. And anaphylactic reaction or anaphylactoid reaction can happen in many of the parenteral iron preparations, and this should be avoided in patients with kidney disease. Okay. Now, acute iron poisoning may happen when there is more iron. Mainly it happens in the infants and children, very rare in the adults. Vomiting, abdominal pain, hematemesis, diarrhea, lethargy, etc. can happen. Cardiovascular collapse and death also can happen. Treatment is mainly by the, remember this desferrioxamine. So chelating agents will be dealt with in the last part of your syllabus. So remember that there is also there, this desferrioxamine is the iron chelating agent. This desferrioxamine or deferriprone, this is also used in the thalassemia, because in thalassemia we have to give the repeated blood transfusion. That's why there will be iron overload. So acute iron toxicity can also happen. So both in case of the acute iron poisoning, either in the overdose or in the thalassemia, we should use the desferrioxamine, which is a iron chelating agent, remember. So apart from this, there are some miscellaneous or adjuvant hematinics. Details is not there, just remember the name: copper, pyridoxine, riboflavin. These are also under the adjuvant hematinics. Next, coming to the maturation factors. So vitamin B12 and folic acid, these two are known as the maturation factors, because if there is deficiency of these two agents, that results in megaloblastic anemia. What is megaloblastic anemia? There is presence of the large red cell precursors in bone marrow, and their large and short-lived progeny in the peripheral blood. So the basic defect is in the DNA synthesis. So DNA synthesis becomes problematic. So ultimately there occurs more hyperplasia in the cytoplasm, but so ultimately there will be large red cell precursors. But the lifespan of these red cell precursors also very less. So ultimately that also leads to anemia. This is known as the, that's why megaloblastic anemia. And this vitamin B12 and folic acid helps in the maturation of these RBC precursors, appropriate maturation. That's why this is known as the maturation factors. So now coming to the vitamin B12. So vitamin B12 is present mainly in the two forms. One is cyanocobalamin, another is hydroxycobalamin. Two forms is there. These are complex cobalt containing compounds in the diet. What are the dietary sources? Mostly animal sources. So liver, kidney, sea fish, egg yolk, meat, cheese are the main vitamin B12 containing constituents. Vegetable sources only legumes, not by the legumes itself, but by the microorganisms that are harbored in their root nodules. So this vitamin B12 is synthesized by the colonic microflora in our body, but this is not available for absorption in man. The commercial source is Streptomyces griseus. So remember, vitamin B12 is not formed in our body by means of the microorganisms already present in our body. So we have to take the vitamin B12 from outside, and most of the cases vitamin B12 source is different types of the animal source. Daily requirement is approximately 1 to 3 microgram, and in pregnancy and lactation again it is increased to 3 to 5 microgram. So what are the metabolic functions of this vitamin B12? Some of it already have read in the biochemistry. So vitamin B12 and folic acid both are related to different types of the one carbon transfer reactions and different types of the cytochrome metabolism. So the active coenzyme form of the vitamin B12 is the deoxyadenosyl cobalamin, DAB12, and the methyl cobalamin, methyl B12. So these two names are the important, deoxyadenosyl cobalamin and methyl cobalamin. So they help in the conversion of homocysteine to methionine. They are essential for cell growth and multiplication and essential for preventing degeneration of the spinal cord. So these are the metabolic functions. So methionine is needed as a methyl group donor. You already know. Now this requires the tetrahydrofolic acid. Tetrahydrofolic acid is the active form of the folic acid, and ultimately vitamin B12 and folic acid both are required for this metabolism. And purine and pyrimidine synthesis also occurs by means of this one carbon transfer reaction. You can see B12 is converted to methyl B12, again it is converted back to B12, and by means of which methyl tetrahydrofolic acid is converted to tetrahydrofolic acid and homocysteine is converted to methionine. So this is continuing if there is adequate presence of the vitamin B12 as well as the folic acid in our body. Malonic acid is converted to succinic acid by means of the DAB12, the active coenzyme form. And basically this is the link where the carbohydrate and lipid metabolism occurs. The reaction does not require folate and has been considered to be responsible for the demyelination seen in vitamin B12 deficiency due to methyl malonic acid accumulation. So in most of the cases you will see that both in vitamin B12 deficiency or folic acid deficiency, in most of the cases it is indistinguishable. That is, the symptoms most of the cases are similar. We have to supplement both. But this is some of the cases when there is pure vitamin B12 deficiency, you will see problems in the nerve. That is, the demyelination of the nerve happens, and it happens because this conversion does not happen. The malonic acid conversion to succinic acid. So here lies the problem. Again, the methionine is converted to S-adenosine methionine by the DAB12, and it is also important in neurological damage of the vitamin B12 deficiency because it is needed in the synthesis of the phospholipids and myelin. So from this you can see that not only the hematological problem, different types of the neurological problems can also creep in when there is vitamin B12 deficiency. So how it is utilized? Utilization of the vitamin B12. It is present in food as protein conjugates. So it is conjugated with the proteins released by the cooking or by proteolysis in stomach, facilitated by the gastric acid when we are taking the food. Intrinsic factor. Now this intrinsic factor is secreted by the stomach, which is a glycoprotein of molecular weight 60,000. It forms a complex with vitamin B12. So intrinsic factor vitamin B12 complex is formed that attaches to specific receptors to present on the intestinal mucosal cells and is absorbed by the active carrier mediated transport, much like the iron. So vitamin B12 is not absorbed on its own. There will be intrinsic factor is very important, glycoprotein that is released from the stomach. That intrinsic factor attaches with the vitamin B12, and this combination is taken in the different types of the mucosal cells. And then it is goes to the blood and it transported in the blood in combination with the beta globulin known as the transcobalamin. In the iron there is transferrin. Here it is transcobalamin 2 most commonly. Vitamin B12 is not degraded in the body, it is excreted mainly in the bile, and considerable enterohepatic circulation happens. Now in the absence of the intrinsic factor, when there is problems in the stomach, when there is intrinsic factor deficiency due to some autoimmunity, there is malabsorption. Vitamin B12 deficiency develops much more rapidly than when it is due to nutritional deficiency. Nutritional deficiency of the vitamin B12 is rare because vitamin B12 is stored for long period of the time and very minimal amount of the vitamin B12 is required. But the problem is if there is problem in the intrinsic factor, and this is known as the pernicious anemia. Probably you have read something about this in the physiology and biochemistry. So pernicious anemia is basically an autoimmune disease where there is destruction of this intrinsic factor so that the vitamin B12 cannot bind with the intrinsic factor and it cannot get absorbed in our body. So normally only traces of the vitamin B12 are excreted in urine, but when large amount of the dose, that is the pharmacological dose, greater than 100 microgram are given, large part is excreted in urine. Now the hydroxycobalamin form is more protein bound and better retained than the cyanocobalamin. So the same thing, from the diet, it is bound with the intrinsic factor. This intrinsic factor and vitamin B12 is again absorbed, and again it goes by means of the transcobalamin 12 vitamin B12 combinations to different types of the body cells. It is stored in most of the cases in the liver and in different other biochemical reactions. But when the vitamin B12 deficiency happens, for example, when there is inadequate dietary supply. So inadequate dietary supply, it can happen in case of the strict vegetarians in some of the cases. Second is when there is inadequate secretion of the intrinsic factor. So when there is problems of the intrinsic factor, when there is some ileal disease, this is the small intestine, when there is some malabsorption, when there is some ileal disease, there are also problem in the absorption of the vitamin B12. And when there is some congenital deficiency of this transferred protein itself, that is the transcobalamin 2, so that there will be less supply of the vitamin B12 to different types of the cells. So there occurs also deficiency may happen. And again, if there is some some problems in the liver, the storage will be poor, some liver disease, hepatic disease. Or if there is some disease in these areas, that is the respiratory chains, different types of the enzymes. So in these cases, the deficiency of the vitamin B12 can happen. So the same thing, remember the most important thing is the pernicious anemia. It is also known as the Addisonian pernicious anemia, which is an autoimmune disease, destruction of the gastric parietal cells, absence of the intrinsic factor, inability to absorb vitamin B12. Already we have discussed the same thing. Other causes, when there is gastritis, gastric carcinoma, gastrectomy, or malabsorption, or consumption of the vitamin B12 by abnormal flora in intestine. This can also happen. This is some intestinal disease like blind loop syndrome or due to some tapeworm infestation. Nutritional deficiency is rare and increased demand when there is some pregnancy or infancy. In these cases, usually the vitamin B12 deficiency happens. So manifestations of deficiency, how it is manifested? Megaloblastic anemia, already you have seen. When you will examine this under microscope, there will be neutrophils with hypersegmented nuclei and giant platelets are there in the blood film. Glossitis can happen, that is the problems in the mucosa of the tongue. Disturbances due to damage to epithelial structures. And apart from this, the neurological problems is also very much important. Subacute combined degeneration of the spinal cord, very important. So vitamin B12 deficiency may lead to subacute combined degeneration of spinal cord. There may be peripheral neuritis like diminished vibration and position sense. There may be paresthesia, depressed stretch reflex, that is the paresthesia, that is the sensation is not normal. Mental changes may happen, poor memory, mood changes, hallucination, etc. So in most of the cases, the pernicious anemia patients or some patients who have vitamin B12 deficiency, they come with these symptoms, usually the peripheral neuritis and paresthesia, and ultimately that leads to subacute combined degeneration of the spinal cord. So the preparations that is needed for this treatment is cyanocobalamin and hydroxycobalamin. This is the prophylactic dose and this is the therapeutic dose. Details is not required, but these two forms are there. Apart from this, the oral tablets of the methylcobalamin is also there, that can be used for correction of the neurological defects in diabetic, alcoholic and other forms of the peripheral neuropathy. So it has been seen the peripheral neuropathy, problems of the nerve is also quite prevalent when there is diabetes mellitus, when there is chronic alcoholism or in other forms. There is also vitamin B12 deficiency. Here we have to supplement with the methylcobalamin tablets. So methyl B12 is there. So treatment is done. There are different types of the regimens is there. Some are followed in UK and India, some are USA. Either hydroxycobalamin or cyanocobalamin can be given, and it should be given until the neurological symptoms improve, because the hematological symptoms improvement takes time. The blood film changes takes time. The neurological symptoms usually the changes becomes more prominent. So now with the vitamin B12 treatment, it is always wise to add 1 to 5 milligram of the oral folic acid. So we have to add the folic acid and an iron preparation. Already we have seen, because reinstitution of Briggs hematopoiesis may unmask deficiency of these factors. Now when we are giving the vitamin B12, the response is dramatic. Symptomatic improvement starts in 2 days, appetite improves, mucosal lesion heals in 1 to 2 weeks, reticulocyte count increases, hemoglobin and hematocrit start rising after 2 weeks, platelet count normalizes in 10 days and WBC count 2 to 3 weeks. So you can see when we are supplementing with vitamin B12, ultimately the response is quite dramatic. And neurological parameters improve more slowly, may take several months total. So where it is used, prophylaxis. So where there is chance of the deficiency is there. Mega doses are used in neuropathy, psychiatric disease, cutaneous sarcoid, tobacco amblyopia, etc. Cyanide poisoning, in some cases, massive dose of the hydroxycobalamin is most commonly used. So adverse effects are very less. There only anaphylaxis or anaphylactoid reaction can happen. Otherwise, it is not important. Now coming to the folic acid is the deficiency or everything is more or less in line with the vitamin B12. Basically, you can see the dietary sources are liver, green leafy vegetables, egg, meat, milk, etc. And chemically, it is a pteridine plus para-aminobenzoic acid and glutamic acid, this combination. So this is the combination of the folic acid. Mainly it is absorbed in the jejunum part of the intestine. Daily requirement is less than 0.1 milligram, but it is increased in pregnancy, lactation, or when there is high metabolic activity. Metabolic functions is more or less again similar to the vitamin B12. So folic acid is transformed to the tetrahydrofolic acid. Already you have read in the biochemistry, and this tetrahydrofolic acid is important for different types of the 1 carbon transfer reactions, be it conversion of homocysteine to methionine or generation of different types of the DNA constituent like thymidylate, conversion of serine to glycine, purine synthesis, histidine metabolism, etc. Details is not required, so you already know that these are the areas where the tetrahydrofolic acid acts. The utilization, again, it is present in different types of the foods. It is ubiquitous, quite prevalent in different types of the fruits and vegetables. And again, it is associated with the proteins as polyglutamates. It is goes within our body. Total body store 5 to 10 milligram. Liver takes large part of it and stores, and some part of it is excreted through the stool. This is not so important. Now the deficiency cause the similar in accordance to the vitamin B12, like there may be malabsorption, there may be biliary fistula, because the enterohepatic circulation of this vitamin B12 and folic acid is quite high. If the enterohepatic circulation is also becomes less, there will be deficiency. Chronic alcoholism, this is important. So in chronic alcoholism, there will be deficiency of the folic acid. So if we are treating a chronic alcoholic patient, we have to supplement with the folic acid. Increased demand, again the pregnancy, lactation, rapid growth period. You know that in pregnancy the folic acid is usually supplemented. Drug induced can happen. So prolonged therapy with anticonvulsant drug. Already you have read that phenytoin, phenobarbital, primidone, if they are continuing for long period of time, there may be some folic acid deficiency and megaloblastic anemia can happen. And oral contraceptives also. So in these cases, we have to supplement with the folic acid. So manifestations, again the megaloblastic anemia, and it is indistinguishable with the vitamin B12 deficiency. More or less this is the similar. Neural tube defects including spina bifida in the offspring may occur due to maternal folate deficiency. So in pregnancy, the folic acid supplementation is very important, irrespective of their folic acid store. So if there is folic acid deficiency in pregnancy, there may be spina bifida or neural tube defect may occur. So this is very important for your viva or examination. So folic acid deficiency in pregnancy may occur, leads to the neural tube defect. That's why high doses of the folic acid is given. And if there is any history of the previous abortions, or if there is any complicated pregnancy, in these cases we have to give still higher doses of the folic acid. Okay, remember. So uses of the folic acid, megaloblastic anemia, same thing, we have to give the vitamin B12 and the folic acid. But the important thing is this. So folic acid should never be given alone to patients with vitamin B12 deficiency, because it may occur, but neurological defect may worsen due to diversion of the small amount of the vitamin B12 present in body to hematopoiesis. So when we are supplementing it we have to give both this vitamin B12 and folic acid. So when there is vitamin B12 deficiency, or if the patient is diagnosed as megaloblastic anemia and we are giving only with the folic acid without giving the vitamin B12. Now we have already seen this vitamin B12 and folic acid, their metabolism is intertwined with one another. So ultimately all this leads to formation of the DNA synthesis in the neurons, and if there is deficiency of the vitamin B12, demyelination happens. So small amount of the vitamin B12 already present, that will be diverted to the hematological improvement. So there will be less vitamin B12 available for the neurological front if we are giving only folic acid without the supplementation of the vitamin B12. So deterioration of the neurological front will happen. So this is important. Prophylaxis of the folate deficiency, already you have seen. The pregnancy, very important. Pregnancy, you have to give the folic acid, or in some cases very high dose of the folic acid is to be given. Another thing is methotrexate toxicity. So when we are giving the methotrexate, so methotrexate, there occurs some problems in the DNA. You will read the methotrexate later, or something you have already read in the rheumatoid arthritis chapter also. So folinic acid is basically an active coenzyme form which does not need to be reduced by dihydrofolate reductase before it can act. So what happens? Methotrexate is basically used in different types of the chronic disease and in cancer. They blocks the tetrahydrofolic acid, this dihydrofolic acid reductase. So conversion of the folate to its active form, tetrahydrofolic acid, is blocked mainly in the diseased cell, that's the cancerous cells. But some part of this block also happens in the normal cells also. When these problems occurs in the normal cells, there occurs some folic acid deficiency. So we have to supplement with the another derivative of the folic acid known as the folinic acid. This folinic acid does not need to be converted to the tetrahydrofolic acid, the active coenzyme form. That's why the folic acid deficiency will not happen. So when we are using the methotrexate or in methotrexate toxicity, again we have to supplement with the folic acid, most commonly folinic acid or leucovorin or cytophoram factor or 5-formyl tetrahydrofolic acid. Same thing. This is to be given. Adverse effect, there is very lesser adverse effect with this folic acid, not needed details. Next, coming to the erythropoietin. Erythropoietin, again this is important as a short note. So erythropoietin is released from the kidney. In the molecular weight 34,000, it is produced from the peritubular cells of the kidney, essential for normal erythropoiesis. Now when there is anemia and when there is hypoxia, that will be captured by the renal tubular cells, and that leads to the more secretion of the erythropoietin. That stimulates proliferation of the colony forming cells of the erythroid series, induces hemoglobin formation and erythroblast maturation, releases reticulocytes in the circulation. So when there is anemia or hypoxia, that are sensed by the peritubular cells in the kidney. It induces erythropoiesis in a dose-dependent manner, but has no effect on RBC lifespan. That is, just increase the erythropoiesis. There are recombinant form of erythropoietin is there, epoietin alpha and beta, that is available for the treatment. The primary indication where it is used, primarily erythropoietin is used, remember, in the chronic kidney disease, anemia with chronic kidney disease, because in chronic kidney disease the anemia happens due to low erythropoietin level. So when the hemoglobin is less than 8 gram per deciliter, we have to give approximately 25 to 100 unit per kg subcutaneous or IV 3 times a week. Mostly this is the common dose. We have to start with the low dose and titrate so that the hematocrit reach the 30%, hemoglobin approximately 10 to 11 gram per deciliter. So chronic kidney disease, anemia in chronic kidney disease is the main indication for erythropoietin. Apart from this, there are some other indications, not details required, like anemia in AIDS patient with treatment with girobudin, cancer chemotherapy induced anemia, and preoperative increased blood production for autologous transfusion. Okay. So when we are giving the erythropoietin, already we have seen, we have to give the parenteral iron, because there will be Briggs erythropoiesis, and erythropoiesis also needs the iron. Adverse effects may be due to sudden increase in hematocrit, blood viscosity and peripheral vascular disease. So since there is Briggs erythropoiesis, the viscosity of the blood is Briggsly increased. So there may be some problems like increased clot formation in the AB shunt. Most of the cases, these patients are on hemodialysis. You know, in hemodialysis, there is done a arterial venous shunt, AV shunt. It can be blocked when this erythropoietin is given. Hypertensive episodes can happen, that is increased blood pressure. Serious thromboembolic events, that is sudden stroke can happen. Occasionally seizures can happen. The newer ones is the darbepoetin alpha. Darbepoetin alpha is a hyperglycosylated modified erythropoietin which are T-half greater than 24 hours, longer acting and can be administered once weekly. So this is about the erythropoietin. Now some minor ones, just remember the name, myeloid growth factors. Details is not required. Basically these are required for the proliferation and differentiation of myeloid cell lines. So when there is some neutropenia or when there is some granulocytopenia, when we are using the cancer chemotherapy or in leukemia, we have to increase the WBC count or increase the different fractions of the WBC. We have to use these myeloid growth factors or thrombopoietic growth factors. The name, remember the recombinant human GM-CSF. GM-CSF is granulocyte macrophage colony stimulating factor. Already you have read in the physiology. The name of the drug is the sargamostim. It is used to stimulate the myelopoiesis, sargamostim. And recombinant human GCSF. GCSF is only granulocyte colony stimulating factor. The name is the filgrastim. Filgrastim is used to increase the neutrophil production. So in patients receiving the cytotoxic chemotherapy, that is the patient have already have cancer or leukemia, the patient is taking chemotherapy, this can accelerate neutrophil recovery because neutropenia is very common problem of the cancer chemotherapy that may lead to overwhelming infection. So this can help in this controlling the infection, leading to a reduction in the duration of the neutropenic phase. Thrombopoietic growth factors is also there. So thrombopoiesis, that is the platelet count, is also decreased due to the chemotherapy. Recombinant interleukin 11, known as the oprelvecin. This was approved for use in patients undergoing chemotherapy for non-myeloid malignancies with severe thrombocytopenia. When there is severe thrombocytopenia, non-myeloid malignancy, we can give the oprelvecin. Oprelvecin is a human interleukin 11. Apart from this, there is thrombopoietin and recombinant human megakaryocyte growth and development factor was also there, but it is largely not used. Recently, these two are also used, romiplastim and L-thrombopag. These are basically used in immune thrombocytopenia and severe aplastic anemia. So these are again severe ITP, that is the idiopathic thrombocytopenic purpura. This is a disease, and aplastic anemia, we can use the romiplastim and L-thrombopag. So these are the different types of the growth factors. So this is all the growth factors. Lastly, this is details not required, plasma expander. So when there is shock, when there is some road traffic accident, we have to supplement our extravascular volume with a large amount of the fluid. So we may need the fluid, we may need the blood, but if it is not available, we have to use the plasma expanders. So basically these are high molecular weight substances which exert colloidal oncotic pressure when infused IV, retain fluid in the vascular compartment. Mainly remember, plasma expander is used only to correct hypovolemia due to loss of plasma or blood, mostly in case of the road traffic accidents. Okay, so plasma expander. Human plasma or reconstituted human albumin would seem to be the best. However, due to this human plasma, there may be transfusion, there may be some infection or HIV, serum hepatitis, etc. can happen. That's why synthetic colloids are used more nowadays. So what are the desirable properties of the plasma expander? So they should exert oncotic pressure comparable to plasma, should remain in circulation, not leak out in the tissues, should be pharmacodynamically inert, should not be pyrogenic or antigenic, should not interfere with blood grouping, should be stable, easily sterilizable and cheap. Just remember these desirable properties of the plasma expander and the names. So these are the 4 things that is mainly used as plasma expander. Human albumin, dextran, polygellin and hetastrase. Of this polygellin and hetastrase is very much costly. Okay. So details is not required. You can see from the slide. This is not required. Just remember this use of the plasma expanders, where it is used. So primarily as substitutes for plasma in conditions where plasma has been lost or has moved to extravascular compartment. So apart from the road traffic accident, there is another condition where this happens. This happens in the burns. So in the acute phase of the burns, there occurs some this loss of the fluid to the move to the extravascular compartment from the intravascular compartment in severe burn. So in those cases, we have also supplement different types of the plasma expander. If there is hypovolumic shock, that is there is severe blood loss or fluid loss. If there is endotoxic shock, that is severe septicemia happens, severe trauma and extensive tissue damage. In all of these cases, we have to use the plasma expander. It can also be used as a temporary measure in case of whole blood loss. Still the same can be arranged, but they do not have oxygen carrying capacity. This is remember. So ultimately we have to give the blood, but for the blood transfusion we have to procure the blood, we have to cross matching, grouping, etc. For this we need time, and when there is emergency like this road traffic accident, we have to immediately increase the intravascular volume. That's why we have to give the plasma expanders, but they do not increase the oxygen carrying capacity of the blood, oxygen carrying capacity. Only blood have oxygen carrying capacity due to their RBC. So apart from albumin, other plasma expanders should not be used for maintenance of plasma volume in conditions like burns where protein leak out with fluid for several days. So usually in burns you will see in burn unit that albumin is usually given, and there are some contraindications to plasma expander when there is severe anemia. That is already the oxygen carrying capacity is very less, so we have to transfuse the blood first. When there is cardiac failure, because if we are expanding the plasma, the heart have to do more work. That's why there will be more chances of the more failure, cardiac failure. Pulmonary edema, this is similar to the cardiac failure. Liver disease, hepatic failure in some of the cases. Again, there will be already hyperperfusion and renal insufficiency when the kidney is already very less perfused. In those of the cases, we should not use the plasma expanders. So this is all about the hematinics. So within the hematinics, you have to read about the iron absorption. This is very much important. I have already told the picture and how the iron is absorbed in our body. The second thing is how the iron treatment is done to the anemia. What are the iron salts? Third is parenteral iron therapy. This is very important for your short note and in your viva. What are the indications of the parenteral iron therapy and what are the agents? Okay. Next, coming to the vitamin B12. Vitamin B12, just remember what are the agents that is required for vitamin B12. Vitamin B12 metabolism is usually not needed, but where vitamin B12 deficiency occurs, mainly pernicious anemia, and how it is to be treated. How the vitamin B12 and folic acid to be given together, whether the folic acid should be given only singly or whether it should be given together with the vitamin B12. Next, coming to the erythropoietin, again erythropoietin can come as a short note. What is erythropoietin? What are the indications mainly, and what are the adverse effects of the erythropoietin? You have to just remember the name of this myeloid growth factor or the thrombopoietic growth factors, and just know the names of these plasma expanders and what are the indications of the plasma expanders. So thank you.
So these all progenitor cells have a common hematopoietic stem cell origin. They have a stem cell origin. From that stem cell, these stem cells are converted into the multipotent progenitor cell. That multipotent progenitor cell can be differentiated into any committed type. Commitment হয়ে গিয়েছে। সে কি অ্যারাইজ করতে পারে? মাল্টিপোটেন্ট প্রোজেনিটার সেল থেকে কি অ্যারাইজ করতে পারে? আইদার লিম্ফয়েড প্রোজেনিটার সেল অ্যারাইজ করতে পারে অথবা মাইলয়েড প্রোজেনিটার সেল অ্যারাইজ করতে পারে। ইভেন এই মাল্টিপোটেন্ট প্রোজেনিটার সেল থেকে এরিথ্রয়েড প্রোজেনিটার সেল অ্যারাইজ করতে পারে। ঠিক? সো দিস early progenital lymphoid cell, they committed into 3 types of cell. আমরা যখন পেরিফেরাল ব্লাড স্মিয়ারে লিম্ফোসাইটের কথা বলি, তখন বেসিক্যালি কি কোন কোন লিম্ফোসাইটের কথা বলি আমরা? আইদার বি সেল, বি লিম্ফোসাইট or T lymphocyte, or one special type of lymphoid cell which is known as natural killer cell. So they have all common progenitor cell known as early progenitor lymphoid cell. So this early progenitor lymphoid cell committed into three type of progenitor cell of three different kind of lymphoid cell. So that might be pro NK cell, that is progenitor NK cell, progenitor B lymphocyte, B cell, progenitor T lymphocyte. They converted into pre NK cell, pre B cell and pre T cell, and these are all occurring within the bone marrow. But when this B cell, T cell, pre-B cell, pre-T cell, pre-NK cell, they committed into mature NK cell, B cell or T cell in peripheral smear, we can see them within the peripheral bar smear. Clear? Maturation ta clear hoyeche? It's a very beautiful pictogram taken from our beautiful Robbins. একদম ইজি করে বলা আছে। একই রকম ভাবে আর্লি প্রোজেনিটার, মাইলয়েড প্রোজেনিটার, আর্লি লিম্ফয়েড প্রোজেনিটারের মতন আর্লি প্রোজেনিটার উইথ মাইলয়েড পোটেনশিয়াল, দে মাইট converted into or committed into myeloid series. So what they are known as colony forming unit mixed MX, mix মানে হচ্ছে granulocyte, myeloid and eosinophil, granulocyte, monocyte and eosinophil, or they may committed into colony forming unit of basophil, megakaryocyte or erythroid cell. See, এখানে লিম্ফয়েড সেলের প্রি NK, B and T সেল পর্যন্ত ম্যাচুরেশন হয়েছে, বাট এখানে এই ম্যাচুরেশন মানে মাইলয়েড, আমরা যারা নিউট্রোফিল দেখতে পাচ্ছি তার কমিটমেন্ট হচ্ছে এই কলোনি ফর্মিক ইউনিট গ্রানুলোসাইট সিরিজ থেকে। একই রকম ভাবে মোনোসাইটের কমিটমেন্ট হচ্ছে কলোনি ফর্মিক ইউনিট মোনোসাইট সিরিজ থেকে, অর ইভেন ইউসিনোফিলের কমিটমেন্ট হচ্ছে কলোনি ফর্মিক ইউনিট ইউসিনোফিল থেকে। ক্লিয়ার? And they are converted into blast. These are known as myeloblast, monoblast, eosinoblast or basophil blast, megakaryoblast, which converted into megakaryocyte, and from the megakaryocyte we get the platelet. একই রকম ভাবে these colony-forming unit erythroid series are converted into the erythroblast and ultimately the erythrocyte. So anything, any abnormality related to this, up to pre-NK cell or pre-B cell or pre-T cell, this commitment of precursor, any abnormality up to this level in lymphoid series or up to this level of myeloid series, any assault, any oncogenetic abnormality, any mutation, any growth signal abnormality, any progenitor abnormality related up to this commitment of precursor cell, যদি ম্যাচুরেশন এই লেভেলের পরে না হয় আমরা কি পাবো? ইম্যাচিওর সেল পাবো। সেই ইম্যাচিওর সেলের প্রলিফারেশন হবে। Not only this committed precursor cells are not get into mature state, but also due to some activation of oncogenic factor or oncogene activation, they are getting proliferated, huge number proliferation. এই সেলগুলোই যখন ম্যারো থেকে স্পিলেজ হয়ে বোন ম্যারোতে মানে ব্লাডে আসবে তখনই সেই কন্ডিশনটাকে আমরা বলবো অ্যাকিউট লিউকিমিয়া। So basically acute leukemia means excessive proliferation of hematopoietic immature progenitor cell. পুরো ডিসকাশনটা বুঝলে? কনফিউশন কারো থাকলে এখনই প্রকাশ মানে অ্যাকচুয়ালি বলো। Any doubt has to be cleared before going any kind of discussion. আছে কনফিউশন? বুঝেছো কি বলতে চাইছি? ম্যাচুরিটি হচ্ছে না এই সেলগুলোর, প্রি বি সেল, প্রি টি সেলের ম্যাচুরিটি আপ টু এনকে সেল বা বি লিম্ফোসাইট বা টি লিম্ফোসাইট পর্যন্ত হচ্ছে না, অথবা কলোনি ফর্মিং ইউনিটের বিভিন্ন টাইপের যে কলোনি ফর্মিং ইউনিটগুলো আছে তার ম্যাচুরিটি আপ টু এরিথ্রয়েড সিরিজ মানে আরবিসি, প্লেটলেট, বেসোফিল, ইওসিনোফিল, মোনোসাইট, লিম্ফোসাইট এখানে হচ্ছে না। So these immature cells are not going to mature state either, and due to the virtue of some activation of proto-oncogene, they are getting proliferated. So these immature progenital cells are spill out into blood or different lymphoid organ like spleen, like bone marrow or liver. This whole scenario is known as leukemia or lymphoma. If these immature cells are going into blood itself, it is known as leukemia. If they are going into different organ itself, that might be hematolymphoid organ or that might be different systemic organ like skin, like gastrointestinal tract, like mediastinum, like kidney or anything, any kind of systemic organ, these immature cells are getting proliferated. That condition is lymphoma. There is no such barrier of leukemia or lymphoma per se except the location. If lymphoma, mane if these progenitor cells are involving extra hematopoietic series, stem, extra hematopoietic organ like skin or kidney or even hematopoietic organ like lymph node, bone marrow, spleen, etc., etc., there will be, of course, organomegaly. So if the lymph node is involved, lymphadenopathy. If the spleen is involved, splenomegaly. If the kidney is involved, renomegaly, liver, hepatomegaly, etc., etc., and some others. Others টা আমি পরে বলছি। So basically যদি আমরা মাইলয়েড সিরিজের লিউকেমি নিয়ে কথা বলি, then we have to discuss all these things under the acute myeloid leukemia. But WHO এই হোল হিমাটোলিম্ফয়েড নিওপ্লাজমকে বেসিক্যালি একটা খুব কঠিন একটা ক্লাসিফাই করেছে, কঠিনভাবে ক্লাসিফাই করেছে। This is the whole classification according to the 2022. We are talking about the hematolymphoid neoplasm, not only the malignancy. We are talking about the neoplasm portion. So that could be benign, that could be malignant, that could be any reactive condition also. Fine, neoplasm, any growth, excessive growth, neoplasm. So that could be benign, that could be malignant. তোমরা বুঝে গেছো benign আর malignant এর মধ্যে পার্থক্য কি? So this first entity, myeloid precursor lesion, these are lesion, these are even not even malignancy, but their origin is myeloid series. So this is one group. Second group is myeloproliferative neoplasm. These might be benign, might be malignant. Mostly these are malignant condition, but the origin is myeloid series, and there is excessive proliferation of myeloid series. Fine. Third, mastocytosis, mast cell proliferation. That could be benign, that could be malignant. Fourth group, myelodysplastic neoplasm. আবার এখানে চলে এসো। These are terminally differentiated cells. These are hello. These are terminally differentiated cells. See, myeloblast, monoblast, eosinophiloblasts, these are present within the marrow and these are present within the blood. But if even in maturation of these terminally differentiated cells are getting hampered, সেখানে কোনো একটা প্রবলেম হচ্ছে, মাইলোপ্লাস্ট থেকে নিউট্রোফিলে, ইভেন নিউট্রোফিলটারও স্পিলেজ হচ্ছে না। ওয়াই? বিকজ দিস নিউট্রোফিলস আর নট ফাংশনালি or anatomically mature. Unless and until a cell is anatomically or functionally mature, they are not getting into blood in a mature state. So, এই কন্ডিশনটাকে কি বলে? যখন কোনো ইম্যাচিওর সেল বোন ম্যারোতে বা পেরিফেরাল ব্লাড স্মিয়ারে এক্সেসিভলি থাকে, বাট দে আর নট গেটিং ম্যাচিওর। No, this is known as ineffective erythropoiesis or ineffective hematopoiesis actually. Ineffective hematopoiesis. So, this myelodysplastic neoplasm is associated with ineffective erythropoiesis of progenitor cells. Fine, বুঝেছো? Fifth. These ineffective erythropoietic cells are getting proliferated. This condition is known as myelodysplastic/myeloproliferative neoplasm. Ineffective hematopoietic cells are getting proliferated. Example, polycythemia vera. কি হয় সেখানে? Excessive proliferation of erythroid precursor cell. Essential thrombocytosis, excessive dysplastic megakaryocytic proliferation. Dysplastic, not mature. যদি mature হতো তাহলে that could be a malignant portion, but this is dysplastic. This is anatomically and functionally these are not mature. Myelofibrosis, fibroblast is a component of bone marrow. Dysplastic fibroblast proliferation হচ্ছে। বোঝা গেল? These are known as myelodysplastic myeloproliferative neoplasm, MDS/MPN. Sixth category, acute myeloid leukemia, যেটা নিয়ে আজকে পড়ব। Seventh, myeloid neoplasm secondary, means this myeloid neoplasm occurring due to some secondary causes that might be some under the effect of genotoxic drug, or this myelodysplastic syndrome is converted into acute myeloid condition. This is known as myeloid neoplasm secondary. Eighth condition is myeloid/lymphoid neoplasm. There is no clear cut boundary. We are not differentiating it as lineage specific neoplasm. মাইলয়েড লিনিয়েজ বা লিম্ফয়েড লিনিয়েজ আমাদেরকে ডায়াগনোসিস করতে হয় সেপারেটলি, বিকজ দে হ্যাভ আ ডিফারেন্ট টাইপ অফ টার্গেটেড থেরাপি। The treatment protocol of myeloid neoplasm is totally different from lymphoid neoplasm, but this category has both the features of myeloid and lymphoid neoplasm. Ninth category is acute myeloid leukemia of myxoid or mixed or ambiguous lineage. এটা একটু পরে আসবো। মানে যখন অ্যাকিউট লিউকেমিয়াও থাকছে তখন সেটা অ্যাকিউট মাইলয়েড না অ্যাকিউট লিম্ফয়েড সেটাকে ডিফারেন্সিয়েট করার জন্য যে ক্রাইটেরিয়াগুলো থাকে সেই ক্রাইটেরিয়া দিস ক্রাইটেরিয়াস আর জাম্পড আপ উইথ ইচ আদার। তাহলে আমরা যদি একটা প্রত্যেকটা প্রিকারসার সেলগুলোকে নিয়ে নিই, ঠিক আছে, অ্যাপার্ট ফ্রম দ্য মাইলোব্লাস্ট, সাপোজ দিস ইজ নিউট্রোফিল, the precursor metamyelocyte, myelocyte, promyelocyte, myeloblast. ফাইন, এবার কি নেব? মনোসাইট নিই। promonocyte, monoblast, then myeloblast, ঠিক। নেক্সট যদি এরিথ্রয়েড সিরিজ নিই, এরিথ্রয়েড means RBC, এরিথ্রয়েডে বলো এর আগে কি থাকে? নিউক্লিয়েটেড RBC মানে লেট নর্মোব্লাস্ট, ইন্টারমিডিয়েট নর্মোব্লাস্ট, আর্লি নর্মোব্লাস্ট, late, then myeloblast. So these are normoblast. সেটা কমিটমেন্ট কোথা থেকে হয়েছে? মাইলোব্লাস্ট থেকে। একই রকম ভাবে মেগা ক্যারিও সাইট, মেগা ক্যারিও blast, even they are from myeloblast. সো একটা কমন প্রোজেনিটর হচ্ছে মাইলোব্লাস্ট, ফাইন। সেখান থেকে ম্যাচুরেশন হয়েছে মোনোব্লাস্ট, সেখান থেকে প্রোমোনোসাইট, মাইলোব্লাস্ট, নর্মোব্লাস্ট, ডিফারেন্ট কাইন্ড অফ নর্মোব্লাস্ট, আর্লি, ইন্টারমিডিয়েট, লেট, এরিথ্রোব্লাস্ট, মাইলোব্লাস্ট, মেগাক্যারিওব্লাস্ট, মেগাক্যারিওসাইট। আমার যদি এখানে কোনো নিওপ্লাজম হয়, এখানে যদি কোনো অ্যাবনর্মালিটি হয়, অফকোর্স এটা আমাকে পেতেই হবে মোর দ্যান 20%, বাট বাকি সব সেলও থাকতে পারে। কি কি থাকতে পারে? প্রোমোনোসাইট থাকতে পারে, মোনোব্লাস্ট থাকতে পারে, নর্মোব্লাস্ট থাকতে পারে, মেগাক্যারিওব্লাস্ট থাকতে পারে, এক্সেট্রা 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 সব থাকতে পারে। এই ডিফারেন্ট টাইপ অফ ম্যাচুরেশন থেকেই তার ক্লাসিফিকেশনও ডিফারেন্ট হবে, ঠিক? কনসেপ্টটা ক্লিয়ার হয়েছে? এই কনসেপ্টটা ক্লিয়ার করো, খুব ইম্পর্টেন্ট। কিচ্ছু বুঝতে পারবে না যদি এই কনসেপ্টটা ক্লিয়ার না করো। একটা মাইলোব্লাস্ট থেকে গল্পটা শুরু হয়েছে, গল্পটা তারপর বাড়তে শুরু করেছে, গল্পটা ম্যাচিওর পর্যন্ত যায়নি। ম্যাচিওর গেলে সেটার আর অ্যাকিউট থাকতো না, কারণ তার ওই লিনিয়েজটা কি বলেছিলাম, কমিটেড সেলের, প্রোজেনিটার সেলের অ্যাবনর্মালিটি, সুতরাং ম্যাচুরেশন তো শেষ পর্যন্ত যাবেও না। সো দ্য অ্যাকিউট মাইলয়েড লিউকেমিয়া, ইফ we can see under microscope, we not only see the myeloblast but also can see the blast like some cells like monoblast, promonocyte or myelomonocyte or normoblast or megakaryoblast. These are blast known as blast equivalent. এই কনসেপ্টটা ক্লিয়ার করো। তিনটে কনসেপ্ট তাহলে ক্লিয়ার করতে বলেছি। আমি কিচ্ছু পড়াচ্ছি না, যা সবকিছু বই পেয়ে যাবে, আমার পড়ানোর দরকারও নেই, শুধু কনসেপ্টগুলো ক্লিয়ার করো। বই সব লেখা আছে, আমি তো নোবডি, বই আছে। সো এটা এটা দেখো না, পরে বলছি। সো this all together forms the scenario of acute myeloid leukemia. আমরা ফ্যাব ক্লাসিফিকেশন, ফ্যাব হচ্ছে তোমাদের বন্ধু, আমারও খুব ভালো বন্ধু। ফ্রেঞ্চ, আমেরিকা, ব্রিটিশ, তিনজন খুব ভালো মানুষ। তিনটেই আমরা যা কিছু শিখেছি এই তিনটে কান্ট্রি থেকেই শিখেছি। তারা আমাদের জন্য খুব ভালো উপকার করেছিল। কি জানো তো, এইসব বদমাইশি করেনি, এইটা করেছিল। They classify the acute myeloid leukemia into 7 types. See, কনসেপ্টটা বোঝো। আমি প্রত্যেকটা সেল চেনাবো পরে পরে, আগে কনসেপ্টটা বোঝো। Acute myeloid leukemia M0, that means there is undifferentiated acute myeloblast. শুধু মাইলোব্লাস্ট আছে, আর কোনো ডিফারেন্সিয়েশন হয়নি। ঠিক আছে, কিছু সাইটোজেনেটিক চেঞ্জ হয়েছে, দেয়ার আর সাম মিউটেশন, দ্যাট মিউটেশন কজিং or affecting that part of progenitor cell, that mutated progenitor cells are not even matured into second or third stage only. This is totally undifferentiated acute myeloid leukemia, totally undifferentiated, known as AML M0. Fine. Second, this known as AML M0, second is AML M1 with minimal maturation. AML with minimal maturation. Minimal maturation. M2 means with maturation. With maturation. With maturation. কি বলছে ফ্যাব, কি বলছে? Greater number of myeloblasts with less than 10% granulocytic differentiation. Granulocytic, what do you mean by granulocytic differentiation? বি ব্যাচে আমি পড়িয়েছিলাম ইমিউনোহিস্টোকেমিস্ট্রি, বি ব্যাচে পড়েছিলাম, তোমাদের ব্যাচে পড়াই। তোমরা তো আসোওনি সেদিন, তোমরা সবাই বেড়াতে গেলে, ছুটি করলে, যা করেছো করেছো, বেশ করেছো, বেশ করেছো। সেখানে আমি টিউমার মার্কার পড়িয়েছিলাম, টিউমার মার্কার। তো দ্যাট ক্লাস ইজ ওভার। তো তোমরা বলো টিউমার মার্কার কি? আতি থাম, অন্য কেউ বলুক। Anyone other than Shayan, please stand up and tell me what is tumor marker. তোমাদের ইনফ্যাক্ট তোমাদের ফার্স্ট সেমিস্টারেই ছিল। জোরে, লাউড, বি লাউড, ক্লিয়ার কনসেপ্ট করো। এই কনসেপ্টের ওপরে দাঁড়িয়ে আছে গোটা ম্যালিগনেন্সি। প্লিজ, সবকিছু মুখস্থতে হবে না, কনসেপ্ট ক্লিয়ার না করলে প্যাথোলজি পড়া কোনো দরকার নেই, জাস্ট ছেড়ে দাও প্যাথোলজি পড়া। টিউমার সেল, not only the secret cellular wall or that is cell line or within the cytoplasm. This antigen is nothing but the categorizing factor of that tumor. একই রকম ভাবে সেই টিউমারের, মানে সেটা যদি টিউমার নাও হয়, যদি কোনো একটা সেল থাকে যার একটা ক্যাটাগরাইজিং অ্যান্টিজেন থাকবে, তাকে বলা হয় তার মার্কার। এখানে প্রত্যেকটা লিনিয়েজের একদম প্রথমে চলে যাও, এই যে প্রত্যেকটা লিনিয়েজে স্টার্টিং ফ্রম স্টেম সেল টু মাল্টিপোটেন্ট প্রোজেনিটার টু প্রোক এনকে সেল হ্যান ত্যান প্রত্যেকটা সেলের কতগুলো লিনিয়েজ স্পেসিফিক or cell specific or tissue specific some antigen থাকে. These are known as cluster differentiation marker or CD marker. If it is granulocyte series, then this CD marker will be CD13 and MPO. These four are marker of granulocyte blast, that is myeloblast. So what do you mean by this M2? Myeloblast with less than 10, M1 means minimal maturation. এই সিডি মার্কার গুলো সবকটা পাওয়া যাচ্ছে না, কিছু কিছু মার্কার পাওয়া যাচ্ছে, কিছু কিছু তার মানে সিডি মার্কারের কিছু কিছু ডেভেলপমেন্ট হয়েছে, বাকিগুলো ডেভেলপমেন্ট হয়নি। বাট উইথ M2 all CD markers are developed within the cell. তানবীর ঘুমিয়ে পড়েছে। ওকে, NAC means non-specific esterase. Non-specific esterase importance একটু পরে বলছি। M3 pro acute pro myelocytic acute pro myelocytic leukemia. Pro myelocyte হচ্ছে that is also blast equivalent. Maturation হয়েছে up to pro myelocyte পর্যন্ত, যেখানে যে সেলগুলোর differentiation not only the CD marker but also some important genetic change, that change only causing the development of pro myelocyte. সেটা একটু পরে বলছি। M4 means myelomonocytic, তার মধ্যে কি থাকবে? মাইলোব্লাস্ট থাকবে, মাইলোব্লাস্ট তো থাকবেই, মোনোব্লাস্ট থাকবে, আর প্রোমোনোসাইটও থাকতে পারে। So that can be differentiated into M4-1 and M4-2 type. Acute myelomonocytic leukemia, acute monoblastic leukemia. M5 means monocyte only because the NAC, that NAC is non-specific esterase, is an enzyme which only stain the monocytic series, monoblast or promonocyte. That NC will be highly positive in M4 and also less than 80% cases in less than 80% in M4 and almost more than 80% in N5. M6 means erythroleukemia. This erythroid series involved here. So not only the myeloblast but also dysplastic myeloid series or erythroblast series or erythroid series cell পাবো, and mega 7 means acute megakaryocytic and megaloblastic anemia. এটাও টু টাইপের, শুধু মেগাক্যারিওসাইটও পেতে পারি, মেগাক্যারিওব্লাস্টও পেতে পারি। But this classification is very old type classification. Teacher, peripheral blood smear or bone marrow morphology, যেটা আজকে তোমরা শিখবে। থার্ড, cytochemistry, fourth, immunophenotyping, and fifth, cytogenetics or molecular genetic analysis. আমরা যখন ক্লিনিক্সে কোনো পেশেন্ট দেখি আমরা স্টার্ট করি এখান থেকে, তারপর গ্র্যাজুয়ালি এদিকে দেখি, মানে এদিকে নামি। মজার কথা হচ্ছে যখন ম্যালিগনেন্সি অ্যারাইজ করে তখন শুরু হয় এখান থেকে, দ্য কালপ্রিট লাইং ইন দ্যাট লেভেল, এবং আফটার অল আমাদের কাছে যখন আসে ডক্টরের কাছে তখন এই লেভেলে আসে। WHO চাইছে কোনো ম্যালিগনেন্সিকে যখন আমরা বুঝবো, আন্ডারস্ট্যান্ড করব, ডায়াগনোস করব, ট্রিট করব, তখন जड़ में घुसकर उसका मालिक रोग का इलाज कीजिए। That cytogenetic or molecular genetic analysis is the basis of WHO classification of everything, not only this leukemia but also every malignancy. আমরা প্যাথোলজিস্টরা এই নিয়েই পড়ে আছি। কি হয়? এইগুলো হয়। Acute myeloid leukemia with defining genetic abnormalities. Each and every mutation of leukemia are causing some abnormality in progenitor cell, and they are converting into the immature cell in acute in body, and excessively they are released either in the marrow or also in the blood. Like এই একটা খুব ইম্পর্টেন্ট, অ্যাকিউট প্রোমাইলোসাইটিক লিউকেমিয়া উইথ পিএমএল রারা ফিউশন। পিএমএল রারা দুটো ডিফারেন্ট জিন, হ্যাঁ, অল ট্রান্স রেটিনুইক অ্যাসিড রারা, অল ট্রান্স রেটিনুইক অ্যাসিড জিন বলছি, অল ট্রান্স রেটিনুইক অ্যাসিড জিন, এই জিনের ট্রান্সক্রিপশন ফ্যাক্টর হচ্ছে রারা, তার সঙ্গে ফিউশন করছে পিএমএল জিন, যে জিনের ফিউশনের ফলে প্রোজেনিটার সেল ডেভেলপ করে প্রোমাইলোসাইটস, তার কিছু ক্যারেক্টার আছে, সেই ক্যারেক্টার অ্যাকিউট লিউকেমিয়াতে যখন ট্রান্সফর্ম করে তখন তাকে বলে অ্যাকিউট প্রোমাইলোসাইটিক লিউকেমিয়া। Just like this acute promyelocytic leukemia, some other mutation involving this genetic fusion are getting transferred into some abnormalities and different kind of blast and etc. occurring. So these acute myeloid leukemia are occurring due to these genetic abnormalities. So this is the first class of acute myeloid leukemia defining genetic abnormalities. Second class, acute myeloid leukemia defined by differentiation. এটা fair classification অনুযায়ী, like acute myeloid leukemia minimal differentiation M0, without maturation M1, with maturation M2. Acute basophilic leukemia, this is new entity. Acute myelomonocytic leukemia M4, M5, M6, M7. Myeloid sarcoma, it's not only involving the peripheral blood smear but also involving the other site of the body. Fourth, secondary myeloid neoplasm due to cytotoxicity or some germline mutation, or might be due to trisomy 21, that is Down syndrome. Fourth, myeloid lymphoid neoplasm altogether. These are entity which are associated with eosinophilia and these gene genetic rearrangement. Fifth entity, acute leukemia of mixed or ambiguous lineage. খুব ইন্টারেস্টিং এখানে হচ্ছে মিক্সড ফেনোটাইপিক অ্যাকিউট লিউকেমিয়া উইথ BCR ABL1 ফিউশন। এই ফিউশনটা হয় 721 এ যাকে বলা হয় ফিলাডেলফিয়া ক্রোমোজোম। বাট দ্যাট ফিলাডেলফিয়া ক্রোমোজোমে দুই ধরনের প্রোটিন প্রোডাক্ট থাকে, একটা 190 কিলোডালটন প্রোটিন প্রোডাক্ট, একটা 210 মানে 210 কিলোডালটন protein product. This 190 kilodalton protein product is associated with mixed phenotypic acute leukemia with this kind of fusion. But that if that fusion product is 210 kilodalton protein product, that will cause chronic myeloid leukemia. 210. And also KTM2A rearrangement and etc. And mixed lineage phenotype. These are all based on that part, cytogenetic or molecular study. কেন ইম্পর্টেন্ট জানা এগুলো? প্রত্যেকটা লিনিয়েজে প্রত্যেকটা রিঅ্যারেঞ্জমেন্টের স্পেসিফিক টার্গেটেড অ্যান্টিবডি আছে, ওই টার্গেটেড অ্যান্টিবডি থেকে মনোক্লোনাল অ্যান্টিবডি থেরাপি করা হবে। ঠিক আছে, তাই এপিএমএল এর ট্রিটমেন্ট বাকি মাইলয়েড লিওপ্লাজম থেকে টোটালি ডিফারেন্ট। এপিএমএল এর অ্যাকিউট প্রোমাইলোসাইটিক লিউকেমিয়া ট্রিটমেন্ট বাকি সব কিছু থেকে টোটালি ডিফারেন্ট। ওখানে অ্যাট্রা দেওয়া হবে, বাকিগুলোতে দেওয়া হয় না। ঠিক, ওকে। এটা তোমাদের রবিনসে আছে, সহজভাবে আছে, এটাকে ডব্লিউএইচও ক্লাসিফিকেশন এভাবে বলা হচ্ছে। এটা তোমাদের এইটাই তোমাদের সিলেবাসে আছে। অ্যাকচুয়ালি এএমএল বলছি সব বলছি। এএমএল এর যদি ক্লাসিফিকেশন বলে দিস ইজ দ্য ক্লাসিফিকেশন, ইউ হ্যাভ টু রিটেন ডাউন। তোমাদের পরীক্ষায় এই ক্লাসিফিকেশনটা জানা হবে। যদি ক্লাসিফিকেশন বলে মেনশন না করে দিস ইজ দ্য ক্লাসিফিকেশন, যদি ফ্যাব ক্লাসিফিকেশন বলা হয় তাহলে ওই রকম এএমএল, M0, M1, M2, M3 এটসেট্রা। ফাইন, এইটা ফ্যাব ক্লাসিফিকেশন। সো M0 প্রিমিটিভ সেল, M1 এ মাইলোব্লাস্ট পাবো, M2 তে মাইলোব্লাস্ট প্রোমাইলোসাইট পাবো, M3 means hypergranular promyelocyte acute promyelocytic leukemia, M4 এ মোনোসাইট পাবো, মোনোব্লাস্ট পাবো, M5 এ basically M5A and M5B. M5A is only monoblast, M5B monoblast, monocyte and monocyte. M6 erythroblast পাবো and M7 megakaryocyte পাবো। নেক্সট, ক্লিনিক্যাল ফিচার নিয়ে আমি কিছু বলছি না, আমি এমএল নিয়ে কথা বলবো। আমাদের 4টে টাইপের সেল চিনতে হবে। একটা মাইলোব্লাস্ট চিনতে হবে, একটা মোনোব্লাস্ট চিনতে হবে, একটা প্রোমাইলোসাইট চিনতে হবে, আর একটা মাইলোমোনোসাইট চিনতে হবে। মোনোসাইট, মাইলোমোনোসাইট চিনতে হবে। ঠিক আছে, সো কালপ্রিট যেখান থেকে মানে ক্লাসিফিকেশনটাই আসছে যেখান থেকে, অ্যাকিউট অর ক্রনিক, ইটস বেসড অন মাইলোব্লাস্ট। These are basically myeloblasts. These are 18 to 20 micron in size. আগের দিন আমি এটা অ্যাকচুয়ালি মাইক্রোস্কোপে দেখিয়েছি, বাট মাইক্রোস্কোপের প্রজেকশন আজকে খারাপ, সেই জন্য ভার্চুয়াল তোমাকে দেখাতে হচ্ছে। পরের দিন ডেফিনেটলি আমি ক্রনিক মাইলয়েড লিউকেমিয়ার সঙ্গে এটাকে আমি স্লাইডগুলোই দেখাবো তোমাকে, প্রত্যেকটা স্লাইডই দেখাবো। So these are 18 to 20 micron diameter cell. They have a high NC ratio. These cells are having large irregular coarse chromatin and 1, 2, 3, 4, 1, 2, 1, 2, 3, 1, 2, 3, 4, 5, etc. etc. Prominent 2 to 3 nucleoli, and presence of azurophilic granule in bluish abundant cytoplasm. This is the description of myeloblast. তোমাদের নেক্সট এক্সামের একটা স্লাইড এটা। M1 minimal maturation. Why? Because there is no OR rod minimal maturation এ থাকবে না, OR rod plenty থাকবে M2 তে. These are OR rod. These are bluish rod like pinkish rod like material within the cytoplasm. If these OR rods are not like rod structure, instead of rod like structure there is dotted accumulation of pinkish material. This is known as phi body. If these OR rods are present within the cytoplasm in bundle, plenty of OR rod present within the cytoplasm, this is thing that will be known as fagot cell. And this M2 is associated with huge number of fagot cell. Huge number of fagot cell. Third, acute pro-myelocytic leukemia. ব্লাস্ট এখানে পাবে, কিন্তু তার সঙ্গে আরেকটা সেলকে তোমাকে চিনতেই হবে, সেই সেলগুলো হচ্ছে এগুলো। These are reniform nuclei. These are having reniform nuclei. Plenty of phi body, azurophilic granules, some cytoplasmic vacuolation, and the cells are look like buttock or lobulated or kidney shaped or reniform, and have a bluish prominent nucleoli known as promyelocyte. This huge amount of granules within the cytoplasms secrete some coagulating factor. So these are procoagulant granules. When they release within the blood, they will cause some condition known as DIC, disseminated intravascular coagulation, consumption coagulopathy. So this is an important feature of APML. Other feature এর মধ্যে যেটা পড়ে, and this M2 is associated with myeloid sarcoma or gingival hypertrophy or scleroma, and acute monoblastic leukemia. These are monoblast. These cytoplasm having no granule, basically ash color cytoplasm, and they have a indentation and mostly bilobed, and each lobe having one prominent nucleoli. This is acute monoblastic leukemia found in MLM4, MLM5. মাইলোমোনোসাইটিকও পেতে পারি, বেশি পাবো M5 এ, M5B তে শুধু এই সেলই পাবো। So these four morphology is very important for your diagnosis of acute myeloid leukemia. তোমাকে myeloblast চিনতে হবে। So how can I differentiate the myeloblast from lymphoblast? আগে লিম্ফোব্লাস্টটা পড়াবো, তখন বলি। And cytoplasm is blue, granular, and or rot seen. Next, clinical stain can be done to recognize this myeloblast or myelocyte, etc., etc. These are Sudan black B and myeloperoxidase. These two special stains are myeloblast positive. Myeloblast MPO Sudan black B. These special stains are positive for myeloblast. Apart from this, the monocyte, monoblast are positive for peroxide acid skip PASH. So monoblasts are positive for PASH and Sudan black B and myeloperoxide are positive for myeloblast, and non-specific esterase is positive for monoblast. They are specially positive in M4 and N5 AML. এই তিনটে জিনিস মনে রাখবে সাইটোকেমিস্ট্রিতে। তোমাদের সাইটোকেমিস্ট্রি স্লাইড আসবে না, আমাদের সময় আসতো, কারণ আমাদের সময় ওটাই করতে হতো, আমাদের করতে হতো নিজে, আন্ডার গ্র্যাজুয়েটেই করতে হতো, বাট এখন আসবে না। অ্যান্ড ফোর্থ, এটা পরে পড়াবো। অ্যান্ড ফোর্থ, immunophenotyping. Immunophenotyping. That means not only the lineage we have to know, we have to identify which kind of cells we are dealing under microscope. So আমরা শুধুমাত্র মাইলয়েড সিরিজের সেলই জানবো না, আমরা জানবো আর অন্যান্য কোনো সেল আছে কিনা। তাহলে আমাদের জানতে হবে কি, what are the specific immunophenotype present within the myeloid series. So myeloid specific antigens or CD marker are CD13, CD15, CD33, CD117, CD11 and 5 and MPO. And these are common marker for immunophenotyping diagnosis. The mode of diagnosis is flow cytometry. We do the gating of myeloid series cell. বোঝাচ্ছি সেটা, আমি কনসেপ্টটা বোঝাচ্ছি না, বাট গেটিংটা বোঝাবো, কারণ এটা আমাদের প্রতিদিনই করতে হয়। সুতরাং বাইরের এক্সটার্নাল বা কেউ যে কোনো সময় ফ্লো সাইটোমেট্রি গেটিং তোমাদের করতেই পারে। ইনফ্যাক্ট এখন না পেলেও নেক্সট ওয়ানে তো পাবে শিওর। So before that we have to know some common antigens which are used for diagnosis of AML in flow cytometry. কি বলেছিলাম, progenitor cell, multipotent progenitor cell or stem cell. Stem cell marker are CD34, CD117. This is known as c-kit. This is known as c-kit. And HLA-DR. HLA পড়াতে গিয়ে বলেছিলাম কথা। HLA-DP, DQ, DR, HLA-DR। c-kit পরে পড়বে, মনে রেখো এটা, ব্যাস তাহলেই হবে। CD117, HLA-DR. These are marker for progenitor cell. খুবই বিরক্ত লাগছে আমি জানি এখন শুনতে, বাট দ্য আনফরচুনেট ম্যাটার হচ্ছে তোমাদের এইখান থেকেই সমস্ত কোশ্চেন আসে। মাইলয়েড সিরিজ বলেছি, CD13, 33, 15, not only 15, 117 and MPO. মোনোসাইট সিরিজের মার্কার হচ্ছে এই দুটো মনে রাখবে, শুধু অ্যাটলিস্ট এই দুটো মনে রাখবে, CD14 আর CD64, CD14 and CD64, এই দুটো অ্যাটলিস্ট মনে রাখবে। এরিথ্রয়েড সিরিজ, গ্লাইকোফোরিন A and CD71, গ্লাইকোফোরিন A and CD71। মেগাক্যারিওট সিরিজ, CD71 and CD70, 71 হচ্ছে অ্যান্টিজেন টু দ্য GP2A 3B and GP1B9 হচ্ছে CD61, CD41 and CD61 for megakaryocyte লিনিয়েজ। এইবার এসো কি করে ডায়াগনোসিস হয় দেখো। পড়ো, এটা খুব সুন্দরভাবে, খুব এটা তোলার কোনো দরকার নেই, এটা আমি রবিন্স থেকে জাস্ট ছবিটা তুলে এখানে দিয়েছি। প্রত্যেকটা লাইন পড়ো, কত সুন্দর করে বলেছে। সেলগুলো দেখো, যখন মরফোলজিতে আমরা সেলগুলো নিয়ে ডিল করব, দেখো these cells are having huge amount of rods and some azurophilic granules. These are having buttock-shaped nuclei and prominent nucleoli. So morphologically, these are looking as promyelocyte and myeloblast. So this is known as acute promyelocytic leukemia. But how I can confirm that this is an acute promyelocytic leukemia? By immunophenotyping. কি করা হলো ইমিউনোফেনোটাইপিং এ? This immunophenotyping done with APML এর করেনি এখানে, যদি করা হয় জাস্ট, আচ্ছা বেশ পরেরটা বলি। These cells are having indented reniform nuclei, some azurophilic granules, and they are, but these cells are having nucleoli, reniform nuclei, but no azurophilic granules. This is myeloblast, but this is monoblast. So that could be myelomonocytic leukemia or monoblastic leukemia. এখানে করা হলো ফ্লো সাইটোমেট্রি এবং এখানে গেটিং করা হলো। গেটিং মানে these cells are having cluster differentiations, huge number of cells are having CD34 antigen which are clustering within this region. So these are CD34 positive cells, means progenitor cells, but there is no CD64 positive. But in this cluster, they are positive also in CD33 and some amount in CD15. It is CD15 is a marker of mature myeloid cell. So basically, এবার মরফোলজিতে তুমি যদি দেখো, দেখবে round nuclei, some azurophilic granules and prominent nucleoli. This is AML M1, which are positive for, of course, immature progenitor marker CD34, myeloid marker CD33, and mature myeloid cell marker very few CD15. So we diagnose this case as M1. এইটাই প্র্যাকটিক্যাল সিনারিও, এরকম করে ডায়াগনোসিস হয়। ক্লিনিক্যালি আমরা কোনো পেশেন্টকে সাসপেক্ট করি, অনলি সাসপেক্ট করি দ্যাট কুড বি লিউকিমিয়া। আমরা বোন ম্যারো অ্যাসপিরেট করি, বোন ম্যারোতে দেখি পার্সেন্টেজ সেল কত, আমরা এস্টাবলিশ করি অ্যাকিউট না ক্রনিক। অ্যাকিউট ক্রনিক এস্টাবলিশ করার পরে ফ্লো সাইটোমেট্রি করি, ফ্লো সাইটোমেট্রি করে আমরা গেটিং করি উইথ সাম সেট অফ সিডি মার্কার। গেটিং করে আমরা কনফার্ম করি যে কোন লিনিয়েজের সেল ওটা, এবং তারপরেও করি আমরা cytogenetics আর molecular genetics for this portion prognosis, because these cytogenetic or molecular studies are only important in therapeutic purpose, because if this is translocation T15 মানে translocation 15-17, that translocation is causing the fusion of PML RARA, which is causing acute promyelocytic leukemia. The treatment is totally different from other acute myeloid neoplasm. একই রকম ভাবে translocation 821 associated with AML M2 acute myeloid leukemia with maturation. Inversion 16 translocation associated with myelomonocytic leukemia or AML M4. These cytogenetics are abnormalities are associated with some genetic mutation also, like translocation 821 is associated MP1 or SEPA mutation. These are basically marker mutation বলা হয় একে targeted therapy এর against এ আছে and of course some abnormalities associated with genetic alterations we have to diagnose before treating any kind of patient. So if I classify this under the favorable, intermediate and unfavorable diagnosis, these are favorable genetic abnormality, these are intermediate and these are unfavorable. 5q deletion, 7q deletion, 11q deletion, these deletions are associated with myelodysplastic syndrome only. And if the acute myeloid leukemia is secondary to myeloid dysplastic syndrome, that will be have that portion having very worse, very bad prognosis. Only few months to years is the 5-year survival rate. Translocation 922, that is very unfavorable prognosis. That's it. Committed cell থেকে pre B cell, pre T cell, সেখান থেকে peripheral B cell, peripheral T cell. So any abnormality in the level of committed lymphoid series, that abnormality reflects with the acute lymphoblastic leukemia. Simple issue. But B cell lymphoid neoplasm and lymphoma are classified into some only five category. One tumor like condition, যেটা ইভেন তোমাদের সিলেবাসেও আছে, some precursor B cell neoplasm, pre B cell neoplasm, that precursor converted into mature B cell. So any neoplasm involving mature B cell neoplasm সিলেবাসে আছে, তোমাদের পরে পড়াবো, এরপরে তারপরের ক্লাসটায়। ফোর্থ হচ্ছে হজকিন লিম্ফোমা, and fifth plasma cell neoplasm and paraproteinemia. এই সবকটা তোমাদের সিলেবাসে আছে। ইনফ্যাক্ট আজকে কনসেন্ট্রেট করব কি নিয়ে? প্রিকারসর বি সেল নিওপ্লাজম। ও দেখার কিছু নেই, একদিনে দেখার কিছু নেই। আচ্ছা, এটা প্রি, এটা বি সেল। নাও টি সেল, টি এন্ড এনকে সেল একই, টি সেল নিওপ্লাজম, precursor T cell neoplasm, T cell and mature T and NK cell. Again, like acute myeloid leukemia, B cell neoplasm also classified under some genetic abnormalities, and these are these genetic abnormalities. Okay. And of course, like pre-B cell neoplasm, B lymphoblastic leukemia lymphoma, T lymphoblastic leukemia lymphoma are also classified into early T precursor lymphoma leukemia. Acute lymphoblastic leukemia is the most common cancer of childhood. These are classified into two main categories, B cell ALL and T cell ALL. B cell ALL comprise 80 to 85% cases of ALL and T cell around 15 to 20% cases of B cell. B cell ALL, the most common age group involvement is 2 to 10 years, but in adolescent period we usually get the T cell ALL. Prognostically, B cell ALL are excellent, but there are some abnormality but a guarded prognosis in T cell ALL. ক্লিনিক্যালে একটা কথা বলে রাখি, যখনই আমরা ALL নিয়ে কথা বলবো একটা কথা মনে রাখবে, there is a term known as lymphoma acute lymphoblastic leukemia. They may enter into the CSF, may enter into the testicle and mediastinum. In case of B cell ALL, the ALL cells enter into the CSF, and this is very common. Around 70 to 75% cases of ALL, there is CNS involvement. But in case of T cell ALL, there will be mediastinal involvement or testicular involvement. And of course, this is highly heterogeneous because not only the B cell, B cell এর কি বলেছিলাম, progenitor B cell, pre B cell, mature B cell, একই রকম ভাবে progenitor T cell, mature T cell সবকটা থেকেই acute lymphoblastic leukemia হতে পারে. So this is highly heterogeneous. FAB তোমাদের জন্য খুব ভালো কাজ করেছে. FAB acute lymphoblastic leukemia cell ke mainly they categorize this cell into three types: L1, L2 and L3. See, L1 cells are having almost no cytoplasm, so they have very high NC ratio. This chromosome is condensed. ওখানে কি ছিল, লেসি chromosome, but these are condensed chromosome. There is no nucleoli, no rod, no cytoplasmic granules, and this L1 type is around 80 to 85%. Most common type. LL2. Now, they simulate some myeloblast, but the difference is, of course, they have a considerable amount of cytoplasm, but there is no granule, granular, and of course, this is very condensed chromatin, and only 1 to 2 very inconspicuous nucleoli within the nucleus. This is L2. Around 10 to 20%, 10 to 15%, and only less than 5% cases, these cells, very interesting cells. These are not typically lymphoid cells. I mean, these are not typically acute lymphoid cells. See, these cells are having cytoplasm, and that cytoplasm is having so many vacuoles. দেখতেই তো পাচ্ছ এগুলো vacuoles, সমস্ত vacuole ভর্তি, and they are very irregular nuclear border, and they have HPV virus infection, cytomegalovirus infection, and Epstein-Barr virus infection. These are malignant counterpart বা lymphoblastic counterpart of Burkitt's lymphoma. These cells are basically looks like Burkitt. So now the difference is cell size. L1 small cell, L2 more larger than L1, and L3 always big cell. Cytoplasm is scanty in L1, variable amount or moderate amount in L2, and of course greater than all these two types is L3. Small nucleoli in L1, L2 1 to 2 nuclei, and L3 bigger nucleoli. This cytoplasm in L3 is highly basophilic, which is variable in L1 and L2. And of course, the cytoplasm vacuolation is very prominent in L3. এই তিনটে সেলকেই তোমাদের চিনতে হয়। Acute lymphoblastic leukemia. So if I classify this acute lymphoblastic leukemia into pre-B cell or T cell or mature B cell, then we can classify this into pre-B cell type, T cell type and mature B cell type. Burkitt's lymphoma L3 type is mature B cell type. Pre-B cell type has cytogenetic abnormality of translocation 922, translocation 119 and translocation 413. T-type associatory translocation Notch1 gene mutation, একটাই কথা মনে রাখবে, Notch1 gene mutation. PAX5 mutation myeloid series এ হয়। T-cell ALL 14q11 or 7q13 and Burkitt lymphoma lymphadenopathy তে পড়বে Burkitt translocation 814 আরো দুটো ট্রান্সলোকেশন হয়, ট্রান্সলোকেশন 218, ট্রান্সলোকেশন 811। দুটো ট্রান্সলোকেশনে হচ্ছে না বার্কিটে LL3 টাইপ, অনলি ট্রান্সলোকেশন 814 এ হয়। So again একই রকম ভাবে ক্লিনিক্যাল ফিচার বললাম, মরফোলজি বললাম, থার্ড cytochemistry. Cytochemistry means acute lymphoblasts are positive for NAC. One. Second, they are always 100% positive for TDT. 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 Terminal deoxyribonucleotide transferase. TDT positive. একটাই কথা মনে রাখবে। In some cases, NAC positive. And also acid phosphatase positive. Acid phosphatase positive. Phosphatase positive. So what are the immunophenotyping marker? What are the CD marker for L1, L2 and L3? No. যখনই আমরা ইমিউনোফেনোটাইপিং করব তখনই সেলকে মেইনলি তিনটে ক্লাসে ভাগ করব। বি সেল টাইপ, B cell type, T cell type. So we have to classify this thing by CD10 common B cell marker. কাল্লা পাল্লা হয় কে, ঠিক আছে। CD19, CD20, CD79A, ঠিক আছে, CD79A, and of course immunoglobulin G, cytoplasmic। এই কটা মনে রেখো at least। তার মধ্যে CD79A is the best marker। এটা তোমাদের MCQ কোয়েশ্চেন আসবে। CD immunoglobulin, cytoplasmic immunoglobulin G, cytoplasmic immunoglobulin G or superficial immunoglobulin G, এর বেশি কিছু জানতে হবে না। T cell এর মার্কার হচ্ছে CD3, CD5, CD4 or CD8, এই কটাই মনে রাখো। তার মধ্যে CD5 হচ্ছে প্যান টি সেল মার্কার, প্যান T cell marker, but the best marker is CD3. Best marker for the T cell type is CD3. But this has to be differentiated from non-Hodgkin lymphoma also. কারণ non-Hodgkin lymphomas প্রিলেজও অনেকটা acute lymphoblastic leukemia মতনও হয়। সেটা করার জন্য CD45 and LCA করা হয়। কমন leukocyte antigen or CD45 marker দেখা হয়। And if they have to differentiate from Hodgkin lymphoma, then CD15 and CD30. Hodgkin lymphoma is positive for CD15, CD30, but B cell, T cell are not positive for CD3, CD5, etc. etc. এগুলো পজিটিভ হবে। NHL এ এই দুটো পজিটিভ হবে, CD45 and LCA। And cytogenetic marker ultimately বেশি কিছু জানতে হবে না, কিছু ফেভারেবল আর আনফেভারেবল মার্কার। যদি ডিফারেন্সিয়েট করো ফেভারেবল আর আনফেভারেবল, শুধুমাত্র সাইটোজেনেটিক মার্কার নয়, ইন জেনারেল মনে রাখো, if the WBC count is less than 1 lakh, I mean less than 10,000, it is favorable, more than 2 lakh is unfavorable. Female gender as such is favorable, male gender is unfavorable. Age 2 to 10 is favorable, less than 1, more than 10, unfavorable. Chromosomal abnormality, if the chromosome number is more than 50, it is favorable, known as hyperdiploidy, but hypodiploidy is unfavorable. If extra, hematological organs are involved, that means the lymph node, bone marrow, spleen, liver, not bone marrow, spleen, liver, etc. involvement is present, is unfavorable. Extra lymphoid tissue involvement is unfavorable, like CNS or testicular involvement is unfavorable. FAB classification, 1 is favorable, but 2 and of course 3 is unfavorable. Cytogenetics, TL, ALM1 mutation is favorable. Trisomy 4, 10, 17 favorable, but trisomy 9, 21 BCL-ABR fusion unfavorable. MLL gene rearrangement is unfavorable. ভীষণ ইম্পর্টেন্ট কোয়েশ্চেন তোমাদের জন্য, এমসিকিউ আসবে। MLL gene rearrangement is unfavorable prognosis, and if the remission is within 2 weeks after the initiation of treatment, it is favorable. If it is remission more than 4 weeks, unfavorable. So concept এটাই যে কোনো লিউকেমিয়া পেশেন্টকে যখন তোমাদের সামনে আসবে, the onset of different anemia, recurrent infection, thrombocytopenia, that is anemia, neutropenia, thrombocytopenia, organomegaly, lymphadenopathy, etc., etc., in stormy pattern. That is, the clinical features are within a very short period of time. You have to consider the age. If it is middle age group, think about the AML. If it is elderly, think about the secondary AML or myelodysplastic. If it is childhood, that is within 2 to 10, think about the ALL. Okay. Now draw the blood, classify. So you have to identify whether it is blast or not. You have to classify which kind of blast, acute myeloid blast or acute lymphoid blast. After the classification, you have to do the cytogenetic study, cytochemistry study. If it is myeloblast, then myeloperoxidase, Sudan black B positive, NAC positive in M4, M5, NAC positive M4, M5, acid phosphatase diffuse positive also, obviously also M4, M5. But PASH positive, acid phosphatase positive, these are focally positive ALL, and of course TDT positive in ALL. Next, of course, immunotherapy. We have to classify the AML. Already bolechi, myeloblast is positive for CD13, 33, 117 MTO. But ALL are positive in CD19, 20, CD71A, and T cell are positive for CD2, CD3, CD5, CD7 or CD4 and 7. Again, the cytogenetic study, of course, we have to identify which kind of cytogenetic study, because the specific therapy is totally different in case of AML and ALL, because asparaginase, this asparaginase basically causes secondary type of AML. Secondary AML, asparaginase side effect is formation of secondary AML. These are the main contrasting features of AML with ALL. That's it.